One. Sir, we are live.
Hello, good evening and namaskar. Welcome to everyone. We carry the greetings from Pink City, Jaipur. It's a pleasure to welcome you all for the day 2 of Experts Guide to ASH 2021, a preview of the top abstracts. And it's a pleasure to welcome Dr. Upendra Sharma, sir, Senior Consultant Hemato-Oncologist at Bhagwan Mahavir Cancer Hospital, Jaipur. Hello, good evening, Dr. Upendra, sir. It's a pleasure to welcome you for this conference. We request to set the ball rolling, please. Over to you, sir.
Thank you, Tarunji. I welcome all you for this wonderful meeting. Recently, ASH happened at Atlanta 2021 in December. So here we are here to discuss what happened in the ASH in 2021. So it is expert guide to ASH 2021. A brief of all the abstracts, important abstracts. So it is our pleasure to have Dr. Upendra sir here with us. And I'm thankful to all the participants here. So I invite Dr. Ashish for further proceedings.
Yeah. Good evening to all. Good evening to all my respected faculties, colleagues, and pharma person. So first of all, I would like to thank my respected Dr. Upendra sir to giving me this opportunity to conduct today's session. So today's scientific agenda for second day of virtual conference and experts guide to ASH 2021 are CLL, lymphomas, and myelomas that we will cover in 3 sessions. So all are quite interesting topics. So before starting today's session, I would like to invite our well-known personality in the field of oncology, Dr. Hemant Malhotra sir. He was the director of oncology services at Sri Ram Cancer Center in Mahatma Gandhi Medical College and Hospital, Jaipur. So over to sir for the welcome notes. Hemant sir.
Thank you very much, Dr. Ashish. I hope I am audible and visible.
Yes, sir. Clearly.
Thank you very much. So, like my good evening to all of you and my welcome to all of you who are listening to this and attending this Best of ASH meeting. My very sincere thanks to Dr. Upendra for giving me this opportunity and मतलब ये इतना मान देते हैं कि मुझे बहुत ही अच्छा लगता है. Thank you, Upendra. And if the day 1 is anything to judge by, where we had some excellent discussions, our top experts of the country, hematologists and medical oncologists giving their uptake on the ASH abstracts, we expect this day 2 also to be excellent. So as has already been mentioned by Dr. Ashish, today we are going to focus on 3 important diseases, CLL, lymphomas, both diffuse large B-cell as well as follicular lymphomas, and finally we'll end up with multiple myeloma. You know, these post-international and national conference updates are extremely important for most of us because for one reason or the other, we are unable to attend these conferences. And if in a 1 day or 2 day capsule, 2 or 3 hours a day, you can get the gist of these meetings, then it is really a value add and a significant gain of knowledge. So once again, many thanks to Dr. Upendra for organizing this 2-day meeting and for getting us all together and for getting such a fantastic panel of experts on board who are really leaders, thought leaders, work leaders, practice leaders in their fields, and they will be able to pass on their perspective on these groundbreaking abstracts which have been presented at ASH and which have been selected by the scientific committee. So with these words, I'd like to hand over back to the organizing team and my very best wishes to you. Have a wonderful day 2 of this Best of ASH, and may all of us have a major knowledge gain post this CME. Thank you very much once more. Over to you, Dr. Upendra, Dr. Ashish.
You can proceed further. You have to mute. You have to unmute yourself, Dr. Ashish.
Yeah. Thank you, sir. Thank you very much for your kind words, sir. So starting with our first session today, So it says CLL, the recent advances in CLL. So for that, I would like to invite our first chairperson, Dr. Divesh Goyal sir. He is a consultant medical oncologist at Fortis Hospital, Jaipur. And Dr. Ajay Yadav sir, he is a consultant medical oncology at Mahatma Gandhi Medical College and Hospital, Jaipur. So over to sir.
Yeah. Thank you, Dr. Upendra sir and team. And for first session, I will invite Dr. Amrita Ramaswamy. She is a medical hemato-oncologist and stem cell transplant at Artemis Hospital, Gurugram. And she will deliver talk in this targeted therapies in CLL, that is the treatment sequencing and adverse event and management. And over to you, Dr. Amrita.
Thank you, Dr. Goyal. Before I start, I would like to thank the organizing team of this meeting for giving me this opportunity. I would also like to thank AstraZeneca for giving me this opportunity because the session is sponsored by AstraZeneca. Much further ado, I'll just start my screen sharing. I hope I'm audible.
Yes, ma'am.
Thank you. So the topic for me today is basically targeted therapies in CLL because we are moving away from chemoimmunotherapy in CLL. Chemoimmunotherapy has become kind of restricted to a very narrow subset of patients who are found to do well with chemoimmunotherapy. We are more moving towards Bruton tyrosine kinase inhibitors and BCL2 inhibitors. And CLL being a chronic disease, incurable disease, treatment sequencing and side effect management becomes very important because we need to use these therapies in the right order. And obviously, because these are lifelong therapies, we are going to encounter side effects when we treat our patients. And how best to manage these side effects and still maintain a good quality of life is what is important. Now, as I began my talk, we know that CLL is a chronic condition and the median age at diagnosis is 72 years. This is obviously Western literature. In India, the median age at diagnosis tends to be younger. And being an older patient profile, most of these patients, close to 89%, have more than one comorbidity at diagnosis. Now, high-risk CLL is defined by the presence of deletion 17p or the TP53 mutation, deletion 11q, and unmutated IGHV. We can make out very clearly from the Kaplan-Meier curves that patients with unmutated IGHV, which is the blue line, they tend to have a poorer progression-free survival compared to those who have IGHV mutated. And coming to the FISH profile, we see that this line, the dark line, is for patients who harbor the 17p deletion, whereas the normal karyotype seems to be somewhere in the middle. And people who have 13q deletion as the sole abnormality, they are the ones who fare the best. So frontline treatment options in unfit patients tends to be kind of an unmet need, because these patients are not they are not fit for FCR, which used to be the chemoimmunotherapy of choice for fitter patients. This is an unmet need, and they have comorbidities. So we need drugs which are safer and drugs which are less toxic. Now, coming to the evolution of treatment landscape in CLL, gone are the days when we were actually starting with chlorambucil. I don't think chlorambucil people do prescribe these days for CLL. Obviously, chlorambucil does have a role in today's treatment of CLL in combination with obinutuzumab for the elderly, unfit, mutated IGHV, but chlorambucil use has pretty much decreased these days because we have other options. Later on, we had the fludarabine and the purine analogs come along, then addition of alkylating agents to the fludarabine backbone, and then finally FCR evolved around 2000 with BR. In 2014, we had introduction of a BTK inhibitors and the phosphoinositide 3 kinase inhibitors, which are still not accessible to people in India. BCL2 inhibitors still not available in India, but we still have some kind of a backdoor access to BCL2 inhibitors in India. And now we are talking about combinations of these targeted agents with anti-CD20 antibodies. And the future will be doublets or triplets. It will be MRD guided and finite treatment combinations of BTKIs and BCL2 inhibitors, and sometimes even a triplet combination where you combine a BTKI with a BCL2 inhibitor and an anti-CD20 antibody. Now, this is very simple, the treatment flow chart for newly diagnosed CLL. So basically, as I earlier said, chemoimmunotherapy, we can see that in each of these treatment lines, be it IGHV mutated, be it IGHV unmutated, the presence of TP53 mutation or deletion 17p, we can see that very much that ibrutinib and acalabrutinib feature in every single treatment arm. Whereas chemoimmunotherapy, we see it occurring less often, and chemoimmunotherapy is the first line of treatment or the first choice for fit patients and unfit patients who have IGHV mutated and no TP53 mutation or deletion 17p. If we have a fit patient with IGHV mutation and no TP53 mutation, we do FCR. If we have an unfit patient, we consider chlorambucil and Gazyva or obinutuzumab. But the thing that I want to point out in this particular slide is we see that in every arm or in every branch of this diagram, we see ibrutinib or acalabrutinib or venetoclax and obinutuzumab featuring in each and every branch of this treatment chart. Now coming to CLL11 trial. So this was a trial which compared basically single agent chlorambucil with Gazyva chlorambucil and rituximab chlorambucil. And they looked at the progression-free survival, and this is again a no-brainer. So obinutuzumab chlorambucil, which is obviously the more potent type 2 monoclonal antibody, did better compared to rituximab and chlorambucil in terms of progression-free survival. I've finished this. So coming to the phase 3 Resonate trial for newly diagnosed CLL patients. Again, I don't see the reason why we should be comparing ibrutinib and chlorambucil, but obviously those were the comparators in the study. Ibrutinib did better compared to chlorambucil, not unexpected. So the median progression-free survival was not reached with ibrutinib compared to approximately 15 months in chlorambucil. And we see that with ibrutinib, that the response, the depth of response improved the longer that you were on the drug. And obviously ibrutinib did better than chlorambucil, be it mutated IGHV, be it unmutated IGHV. Obviously ibrutinib had better progression-free survival compared to chlorambucil. And side effects of ibrutinib, pretty much well tolerated. The longer you were on the drug, the lesser incidence of side effects. The side effects like arthralgia, body aches, diarrhea, rash, all these tended to settle with time, and they hardly needed dose reductions or dose interruptions. The bothersome side effects are basically hypertension. We need to monitor these patients for hypertension that develops. If they are already on antihypertensives, we need to closely titrate the drugs. We need to be on the lookout for atrial fibrillation and major hemorrhage. These are the major side effects of ibrutinib, but obviously with monitoring, many of these patients can continue to be on these drugs for years together and enjoy the good progression-free survival benefits that we see with ibrutinib. So real-world discontinuation is still there. Around 14 to 23% of patients on ibrutinib discontinue due to adverse events, and 15 to 20% require dose reductions due to adverse events. So this was the CLL14 trial, again in frontline CLL. So basically, it randomized patients to chlorambucil obinutuzumab and obinutuzumab venetoclax. The primary endpoint was looking at progression-free survival. Again, venetoclax, the combination of the monoclonal antibody with the targeted agent venetoclax did better on progression-free survival compared to chlorambucil obinutuzumab. So the 24-month estimate of progression-free survival with Gazyva was around 88% compared to chlorambucil. Now, coming to ibrutinib, as we know, is the oldest Bruton tyrosine kinase inhibitor for which we have the maximum amount of data and phase 3 evidence and phase 3 trial evidence that is available. But due to troublesome side effects and given the fact that the CLL population is an elderly population with comorbidities, an unmet need was a drug which was more selective, which did not have many off-target effects. And we now have acalabrutinib, which is an AstraZeneca molecule. And owing to the selectivity of kinase inhibition, the bothersome side effects that we used to see with ibrutinib can be decreased to a great extent if we put somebody on acalabrutinib. Then we do not have access to zanubrutinib as of now in India. The side effects of ibrutinib are basically attributed to inhibition of TEC, ITK, and EGFR. So since we see that this is basically the half maximal inhibitory concentration, we see that for acalabrutinib, the concentration has to be much higher for inhibition of these kinases. Whereas if we compare to ibrutinib, we see that even a very small concentration or the maximal half inhibitory concentration is much lesser for ibrutinib. That's the reason why acalabrutinib is more selective compared to ibrutinib and obviously associated with a better side effect profile. So this is the same slide that I spoke about last. And the pharmacokinetic and pharmacodynamic studies established that the recommended dosing schedule should be 100 milligram twice daily. And the trials which kind of put acalabrutinib into the forefront, into the limelight, basically are the Elevate TN trial, which was in treatment naive CLL patients. And it was either used as monotherapy or it was used in combination with obinutuzumab. And the third arm, the comparator arm, was obinutuzumab and chlorambucil. The primary endpoint was progression-free survival. And they had numerous secondary endpoints, which also included MRD-based endpoints, the overall response rate, and the time to next treatment, and the overall survival. Now, from these curves, we see very well that basically the yellow line is acalabrutinib monotherapy, the purple line is acalabrutinib obinutuzumab, and the blue line is chlorambucil and obinutuzumab. When it came to deletion 17p or mutated TP53, we see that even though there is not too much of separation between these two lines, acalabrutinib monotherapy is as good as acalabrutinib obinutuzumab. We see a major separation in the curves between the chlorambucil and the acalabrutinib arms. So obviously acalabrutinib monotherapy or an acalabrutinib obinutuzumab combination did better when you had deletion 17p or unmutated IGHV. And we see that the side effects are pretty much what are expected. Grade 3 side effects were pretty much less, but the combination of acalabrutinib obinutuzumab was found to be associated with greater infections and greater chances of cytopenias. It was more myelosuppressive compared to acalabrutinib monotherapy alone. And the cardiac events, basically atrial fibrillation, major bleeding, and hypertension, which are basically the BTKI related side effects, are pretty much not seen in the chlorambucil and in the Gazyva arm. But then obviously the progression-free survival of these two arms speaks for itself. If we are able to manage these side effects or closely watch for these side effects, these two therapies are the way to go, irrespective of prognostic subgroups. Now coming to relapsed refractory CLL, obviously relapsed refractory CLL is a difficult disease. as I said, it's incurable. We need to be sequencing our therapies properly. We see that in relapsed CLL, especially multiply relapsed CLL, the progression-free survival, if you were going to re-challenge with chemoimmunotherapy, is not really great. So if somebody has relapsed, I think the way to go is a BTKI or a BCL2 inhibitor. But then having said that, if somebody has been treated upfront with a BTKI inhibitor or a BCL2, how do we go forward next? So that's an area which I think it's a separate topic in itself. If somebody is treated initially with a targeted agent and eventually relapses, what do we do? Now, this was basically the RESONATE trial, which kind of put ibrutinib in relapsed refractory patients. It was compared with ofatumumab, an anti-CD20 monoclonal antibody. Obviously, the progression-free survival was much, much higher with ibrutinib 44.1 versus 8.1 months. And this was again the ASCENT trial in which they compared acalabrutinib monotherapy with either idelalisib, rituximab, or bendamustine rituximab. Obviously, again, acalabrutinib did well compared to the other, the immunotherapy, the rituximab-based arms. Idelalisib is a drug which I don't think people have used often because it has got various immune-mediated side effects, colitis, pneumonitis. So I have no personal experience with this drug. Acalabrutinib, obviously, again, in this study, it did better compared to the other two arms.
Ma'am, a small request. You have another 5 minutes to conclude.
Yes,
please.
I think I'll wind up quickly. And so conclusions in relapsed refractory CLL, I would just like to say that targeted therapy, obviously, it demonstrated better progression-free survival advantage versus chemotherapy in the relapsed refractory setting, regardless of the patient group. And comparison between a second-generation BTKI and ibrutinib are ongoing. We do not, we do not have much data at this time point, but obviously there are suggestions of decreased cardiac toxicity with a second-generation BTKI like acalabrutinib. Fixed duration venetoclax with rituximab or venetoclax with obinutuzumab, it results in improved progression-free survival and overall survival over chemoimmunotherapy. And it offers an advantage that it is fixed duration compared to a BTKI, which has to be given indefinitely and for life. There is no head-to-head comparison between a R combination and a BTKI. Now, what are the promising options in future? As I've already said, we are looking at BTKI and BCL2 inhibitor combinations. We have various phase 2 data and data for MD Anderson, which kind of suggest that MRD undetectable state can be achieved in CLL. And these studies kind of use MRD undetectability as a surrogate to kind of predict the progression-free survival. Just like in myeloma, we are looking at MRD negative status being a better indicator of, progression-free survival and overall survival. MRD is probably the way to go in the future, even in CLL treatment. We are also looking at triplet combinations in which you add a anti-CD20 monoclonal antibody. So there are various phase 2 trials which are looking at this. For the interest of time, I'll skip these slides. And I would just like to focus, maybe show a few slides showing on adverse event management with BTKIs. Now, just this one slide in which chemoimmunotherapy, the advantage is a finite treatment course. It is ideally used or has got a very definite role in people who have IGHV mutated, and it is probably the only subset of CLL patients in which that would probably be the choice over a BTKI inhibitor or a BCL2 inhibitor. It offers a higher CR, MRD negativity, and a good progression-free survival in this particular subset of patients. Whereas patients who have decreasing fitness, they tend to be poor candidates for chemoimmunotherapy, and people who have a poor risk genetic profile like a complex karyotype or a TP53 mutation, we are moving towards targeted therapy with DCR inhibitors. They do not offer a complete remission. The best that we can aim is probably a partial response, but very good progression-free survival rates, irrespective of the genetic profile. I think I'm running out of time. So I would just like to say that hypertension, atrial fibrillation, and bleeding are kind of the side effects we encounter with BTKIs. They are less so with the second generation agents. Acalabrutinib, a very peculiar side effect of acalabrutinib tends to be a headache. Most of these side effects, they can kind of be managed with either a short course of steroids or just paracetamol. We generally avoid NSAIDs with gluten tyrosine kinase inhibitors for fear of bleeding. Lymphocytosis can be seen, but then this kind of resolves within 2 months. We need to be on the close watch for second primary malignancies. We need to monitor the BP of these patients and also be very cautious about using it in elderly patients with cardiac comorbidities. It is not an absolute indication to kind of discontinue BTK inhibitors, but we need to really address symptoms like palpitations, lightheadedness, syncope, and chest pain, and be on the lookout for arrhythmias in these patients. Hemorrhage and bleeding, direct oral anticoagulants are the drugs of choice in case you need to put somebody on a blood thinner who is also receiving a gluten tyrosine kinase inhibitor, and these drugs preferably should be interrupted 3 to 7 days before surgery. Infections are also a troublesome complication, but there is no standard antibiotic prophylaxis that is recommended when somebody is on a BTKI. I think with this, I'll end my talk, and I once again thank the sponsors and the organizers for giving me this opportunity.
Yeah, thank you, Dr. Amrita. Nice presentation. I think very well covered all aspects of the newer treatment options. If there is any queries from audience. The one query is from Dr. Vishnu Sharma. Do you recommend re-exposure with ibrutinib after grade 3 bleeding?
No, I don't think so. I would not use after grade 3 bleeding. I would not use ibrutinib.
Okay. Is there any query from other attendees? I think no, and we will move ahead on second part, that is the panel discussion. For this, I invite Dr. Pawan Kumar Singh, who is the senior consultant and head of department of the hemato-oncology and bone marrow transplantation, and from Artemis Hospital, Gurgaon. And basic points on discussion is the customizing care in MCL with this BTK inhibitors, evidence and application for therapy selection, sequencing and safety management. Over to you, Dr. Pawan Kumar Singh.
Yeah, thank you. And first of all, I would like to thank Dr. Hemant Malhotra and Dr. Upendra Sharma for arranging this meeting. So we had this yesterday, so this meeting started yesterday and we had great discussions. So today, can you allow me to share the screen? Yeah. Yeah, thank you. So I would like to start here. So we have on, so this is basically, we'll be studying, discussing about mantle cell lymphoma and what is the role of BTK inhibitors in mantle cell lymphoma, and what are the evidence and applications of therapy selection, how to sequence these things. So these are actually a hypothetical case, and the slides have been provided to me by AstraZeneca. So the more important thing is about the discussion part. So so we just hypothesize this case. 55-year-old male, he was diagnosed as pleomorphic histological variant of mantle cell lymphoma on cervical node biopsy, ECOG performance score 1, and the blood count showed WBC 8,500, LDH was high, bone marrow showed involvement by abnormal lymphocytes, and immunophenotype classical of mantle cell lymphoma, Ki67 score 30%, and it was cyclin D1 positive. So obviously the diagnosis is mantle cell lymphoma, and the MIPI score intermediate risk. So I would just like to hear. So So we have on panel Dr. Gaurav, Dr. Amrita, Dr. Amit. So I would start with Dr. Dr. Gaurav there?
Hi, Dr. Pawan. Good evening.
Yeah. Hi, Gaurav. So how do you like to go about this patient? So when you initially newly diagnosed 55-year-old ECOG performance score 1, intermediate risk, and KI 67, 30%.
Yeah, so
what would be your preferred line of management in this patient?
As we have seen, that patient is a young 55 years old man, and his ECOG PS is very good. So mental cell lymphoma, if patient is fit and patient is he does not have any comorbidities, then it is preferable to give him aggressive chemotherapy in the form of high dose RSC or some other combination, or hyper CVAD or other combinations.
What is your? My question is, what is your preferred line? So in this case, what would you prefer to give the induction therapy? What type of chemotherapy? You said you want to go for aggressive chemotherapy. So what regimen would you select for this patient? No comorbidities, performance score 1, good performance score.
In my practice, I start with RCHOP, and second cycle onwards, I take him on RDHAP, and I give RCHOP, RDHAP alternate, followed by followed by stem cell transplant, autologous. So I give about 6 cycles of both. Then, so this is how I go about. I give RCHOP, RDHAP alternate.
Okay. So we have next Dr. Amrita is there. So what would be your, do you agree, would you like to go for same protocol which Dr. Gaurav mentioned, or you have any other preference?
I think I agree with Dr. Gaurav. We can either use alternating RCHOP or RDAP, or maybe just RDAP, and try to put the patient into a CR and then take him up for a transplant.
Okay. So now the question is, if patient does not respond to this, so when would you like to assess for the disease? So we are alternating with DHAP and RCHOP. So at what time point would you like to assess for the disease?
I would like to just treat him with RDAP, and maybe after 2 cycles of RDAP, I would like to look at the disease. And if he appears to be in a PR and has tolerated the previous 2 cycles well, I would like to give him 1 more cycle. And hopefully he should be in a CR after 3 cycles of RDAP, and then consider him for a transplant.
Okay. So we have Dr. Amit Upadhyay. So Dr. Amit, would you agree with the, do you agree with the doing upfront autologous bone marrow transplant in mantle cell lymphoma after achieving maybe PR or CR?
So yes, 55-year-old person definitely will go for SCT. We all know mantle cell, it will eventually come back. So yes, transplant is the goal.
Okay. So next point of discussion will be, is there, and this I would like to ask Dr. Sujit. Dr. Sujit is there? Or Dr. Sudeep Vaniat?
Yes, sir. Yes, sir.
Yeah. So in your practice, do you give maintenance therapy in these kind of patients after autologous bone marrow transplant?
Maintenance therapy, no, sir. I mean, not yet started for that. Mostly those with unfit patients, I prefer giving for 2 monthly into 3 years, or maybe indefinitely if they're post RCHOP or something.
Okay, so we'll go back to our case. The patient, he was treated with at the physician's choice. He was given RCHOP, achieved PR, and the patient then received high dose chemotherapy and followed by autologous bone marrow transplant. And then after that, patient achieved CR. Now, after 2 years later, the patient developed relapse, and now the patient is not a candidate for allogenic bone marrow transplant, no good match. So that means he is now 57 years, and now the patient is having relapse. So, Dr. Gaurav, now how would you like to manage this patient? What will be your preferred line of management?
Dr. I think your patient received autologous transplantation upfront, right?
Yes, relapse after auto 2 years later.
So R-CHOP, autologous and relapse after 2 years.
Yes.
Yeah. So in this case, we can offer him BTK therapy, or if he's unwilling for BTK therapy, then we can offer him BR. Depends upon how willing he is for either of these. So it requires a discussion of finite versus long-term therapy. And if patient is okay with the long-term, then probably BTK inhibitors should be given. This is what.
Okay. And what would be your preferred BTK inhibitor in this patient? Either first line, second line? Because now we have both available.
Yeah, if he's impaneled or if he has too much money, then obviously I would go for acalabrutinib. Then otherwise, ibrutinib generic is available, so we can go for ibrutinib generic also. Depends upon how financially well off he is.
Okay, so you want to give him a BTK inhibitor alone, or with any other combination with MABs or with maybe venetoclax?
I would like to start him on ibrutinib alone, and when or probably I won't use upfront. This is my practice, but there may be different opinions. But I would like to give him only ibrutinib.
Okay, so now next I would like to ask the same thing to Dr. Amrita.
I would agree with Dr. Gaurav. I would also just offer monotherapy with a Bruton tyrosine kinase inhibitor.
And what time would you like to assess the disease? After how much duration of therapy of BTK inhibitor?
We are not looking at a complete response with Bruton tyrosine kinase inhibitors. So at relapse, we need to assess whether patient is actually symptomatic and he needs treatment. If he is asymptomatic and does not treatment, even wait and watch can be one of those options. But then if there is an indication to treat, we should put him on Bruton tyrosine kinase inhibitors. And as to the question of when to assess, I don't think I really know the answer to that question, but I believe we are not looking at a CR with Bruton tyrosine kinase inhibitors. So I really do not know the answer to that question. When to assess.
Dr. Amit, would you like to give your comment on that?
See, I might offer something more also. The patient was given only R-CHOP. He is 55-year-old, maybe 57. And considering that if the physical condition is still good, because we are assuming some...
Yeah, he is now 57,
yes.
So no comorbidities.
Yes, but still, yes. So he should be in reasonably fit status. The choice we can offer probably is definitely ibrutinib or acalabrutinib, but I think one option can again be more chemotherapy with RDAP, because going in future, probably the physical condition will deteriorate, and that chemotherapy option, if it is giving maybe 1 or 2 years more, followed by, after all, it will eventually be relapse, and then we can put on BTK inhibitor. That also can be one line of treatment which was in mind.
But
so I would have definitely discussed that.
Dr. Amit, if we had a donor available, I would kind of see the reason of putting him or treating him with an RDAP and then going ahead with an allogenic transplant. But when we do not have a donor who is available, kind of giving him chemotherapy again, and he's going to relapse eventually. So doesn't it make...
He will. Then we can give BTKI. It is
why
just
not put him on BTKI right from the start?
So
why
we are
expose him to
sequencing.
chemotherapy?
We are eventually sequencing. We all know it is eventually going to relapse. And maybe after 3 years, 4 years, probably the physical condition might not permit some more intensive chemotherapy. That was my rationale, nothing more. Okay. So I'm not saying that I would have decided that, but that was one definitely thought which would have come in mind. And I might have discussed with that also. That also one line. Otherwise, anybody would have preferred BTKI.
Thanks, Dr. Amit.
Okay, Dr. Sudeep, would you like to comment on the same question?
Just since the patient does not have a good match for an allogenic stem cell transplant.
Yeah, that means we are not looking at alternative donor transplant at the moment for this patient.
Yes, sir. So we'll go for a BTK inhibitor till progression. I mean, or then decide on that. So preferably ibrutinib, and if the patient is affordable or reimbursable, like told by my seniors, so go for acalabrutinib in that case.
Okay, so we have two opinions here, means BTK inhibitor till progression. And would you like to add on to that, or single agent BTK inhibitor, and then to assess the response, and then depending on the response, if suppose patient is not responding well, then probably maybe add on some other MABs or maybe venetoclax.
So maybe preferably, if at all, since it is 2 years later, maybe add rituximab pre-challenge for 6 cycles and add along with ibrutinib, then assess the response, then continue ibrutinib till progression as a maintenance.
Okay.
Yes, sir.
So now to Dr. Gaurav, what patient factors do you consider when deciding on treatment and plan and make goals for this patient? Like he's relapsed 57 years. So how would you decide about this? Like Dr. Amit has said that because patient, no comorbidity patient is other, so he would like to give more aggressive type of chemoimmunotherapy rather than going for BTK inhibitors. It means he would also consider that as option.
Pawan, fitness would be number one, I think. Fitness, because there are many treatment options which are available. So fitness, first thing is to check for fitness. If patient is fit enough, we offer him aggressive therapy. And then it comes to patient discretion. If he wants to go ahead with the aggressive chemotherapy followed by transplant, or he does not want too toxic therapy or wants R-CHOP or BR only. So if patient is fit, we have options. We can offer him anything. But in case patient is unfit, then options are limited actually, and it is actually a difficulty. I recently had a patient of 85 years old, so I didn't know what to do. So I put him on ibrutinib upfront. So if patient is unfit, then probably giving BR or LEN-R or maybe even ibrutinib makes a sense. So first is fitness, then is discussion with patient. We have to check for MIPI index, like if he has a aggressive disease or patient has involvement of CNS or GI tract. Or I think this is what we consider. Options are available, but depends upon how we discuss with it.
So this is for newly diagnosed, this is a proposed algorithm.
Dr. Pawan sir, just a humble request. You have 5 minutes to conclude your discussion, please.
Okay. I will try to conclude. Okay. So this is the algorithm for fit for those patients who are fit. So we already discussed R-DHAP is the option, then R-CHOP alternating with R-DAP, then R-MAXI-CHOP or with high-dose cytarabine, then even R-hyper-CVAD also with methotrexate, high-dose methotrexate. This is another option for who are fit for high-dose therapy, then who are fit for conventional chemotherapy. We have option of R-CHOP, then RBAC, then bendamustine rituximab is also an option. Then bortezomib also is an option. For those unfit patient, BR or R-LEN, and then probably for these kind of patient, maintenance rituximab. So this was earlier algorithm. So right now, BTK inhibitors are still not there as a frontline treatment. They are indicated as a second line after patient relapses. So this is NCCN guidelines also says about the same. So yeah, so we have already discussed about this question. What is the ideal time to start BTK inhibitor in relapse refractory mantle cell lymphoma? And so who relapsed? So ideal treatment, so yes, BTK inhibitor are there. So this is the BTK inhibitor therapy we have already discussed. This is based on these data. So this is ibrutinib, and then acalabrutinib monotherapies are there. So showed very good results. Only thing is the adverse events. So in previous talk, I think one question was also asked to Dr. Amrita about patient who already developed the grade 3 hemorrhage, and after that, would you like to re-challenge the patient with the so I would like to have other people opinion. Would you like to change at this point of time? Maybe Dr. Amit can comment on that. So if suppose any patient develops on ibrutinib bleeding complication, and would you like to change it to acalabrutinib or to re-challenge with ibrutinib?
No, definitely. If it is something grade 3 event, it's better to switch on acalabrutinib rather than re-challenging. Grade 1 or 2 is still you can try, but any grade 3 event, change that. This is what my practice is.
Okay. Now the question is, so in elderly patient with comorbidities, so who's relapsed after first line and not responding to second line treatment. So what are the options would you like to go for? Dr. Gaurav, bortezomib plus minus rituximab or venetoclax, CAR T-cell therapy, lenalidomide plus rituximab?
I think Len would be a reasonable choice in our setting.
Okay. So Dr. Amrita, if patient relapses after autologous, would you like to consider BTK inhibitors as bridge to, suppose if the patient is fit and he's fit for next maybe allogenic bone marrow transplant. So would you like to consider BTK inhibitor as a bridge to therapy? Bridge to stem cell transplant?
If patient is fit for an allogenic transplant after he's relapsed after an autologous transplant, I would probably give him chemotherapy and then take him up for an allogenic transplant. Because when we're considering an allogenic transplant, I presume that the patient is quite fit. So I think instead of using a BTK inhibitor with which we do not expect a complete response, I'm not sure whether we can use them as bridging therapy before considering an allogenic transplant.
Okay, if the patient had already received, because in before patient R-CHOP, R-DHAP, then patient achieved CR, then patient after. So what chemotherapy or so would you like to prefer to give? Maybe some other, you said that you want to go for aggressive salvage chemotherapy before taking for allo.
So we can consider an alternative chemoimmunotherapy regimen like maybe BR.
Dr. Amit?
Or R hyper-CVAD, even though I think R hyper-CVAD, if he's fit for an allogenic, then maybe R hyper-CVAD also could be an option.
Yes. Dr. Amit?
See, I think it will depend on the physical fitness. On one hand, we are writing it's elderly with comorbidities, then we are looking for that whether he's an optional candidate for SCT. So we have to somewhere decide that what are the comorbidities, what have been given, what not have been given, because the field is not I don't think there is any standard approach. You have to individualize. You have options of using bortezomib or len plus R. SCT given elderly comorbidities, I don't know how feasible it is, but I can't say that there is a definite answer to that. It has to be individualized.
So would you at the time of relapse?
Sorry, Dr. Pawan. Excuse me.
Yes,
sorry, Dr. Pawan. Time is over, I think, 7:15.
Okay, so we would like to just stop here. So I think we need to, at the time of relapse also, we need to look at the other parameters also, like the morphology of the disease, whether the patient is having high-risk features or not there. Then BTK obviously can be a second line option besides the standard salvage chemoimmunotherapy to get the patient into CR and then patient can be taken for definitive therapy. So thank you all the panelists. I would like to stop here because time is already over. So I would just like to hand over the prize to the organizers.
Yeah. Thank you, Dr. Pawan, and very well discussion about this mantle cell lymphoma. And now next hand over to the Dr. Ashish for next session.
Thank you, Devesh sir and Adhyata sir. So we are proceeding with our second session. Second session is all about recent advances in the field of lymphoma. So for that, I would like to invite our chairperson. So first chairperson, Dr. Deepak Shukla sir. He is a consultant medical oncologist at Manipal Hospital, Jaipur. And Dr. Pankaj Tantia is a consultant hemato-oncologist at Acharya Tulsi Regional Cancer Center in Bikaner. So over to you, sir.
Thank you, Dr. Upendra, for this opportunity to chair this session. So, Dr. Rahul Nathani is a director, bone marrow transplantation and clinical hematology at Max Healthcare Hospital, Saket. He will be speaking on taking the turn to treatment innovation in DLBCL. Over to you, Dr. Rahul.
Good evening, everyone. Thank you very much, organizers, for giving me this opportunity and this topic to talk about. So the topic allotted is taking the turn to treatment innovation in DLBCL, real world insight into integrating antibodies and cellular therapy into patient care. And the data is basically it's an expert's guide to ASH 2021. So we'll first discuss the antibody therapy and bispecific antibodies in DLBCL. So we all understand that, in the upfront DLBCL, all patients together, about 60% will be cured, 40% will be relapsed refractory. And in this relapsed refractory population, we go for second line therapy. In fit patient, we give platinum-based therapy. And if somebody was chemosensitive, we do an autologous stem cell transplant. If somebody was chemo-resistant, then CAR T is the way to go. However, for second line therapy patients who are unfit for therapy, there is a role of novel antibodies. And we'll see what the new data suggests. Now, we have a lot of CD19 targeted antibodies available. So we have a Lonca, we have a TAFA, which is CD19, and polatuzumab, which is again CD79B. We also have 3 CAR T cell constructs available. One is an axi-cell, one is a lyso, and one is a T-Sagen cell. So there was a study of, TAFA plus lenalidomide, and by the way, NCCN, approves it as a second line therapy. And this was basically patients who had received relapsed refractory DLBCL 1 to 3 prior regime. And TAFA was initially given, every week in the first 3 cycles. And after that, it was every 15 days till 12 months. And if it had more than stable disease, it was continued. And the authors found that 32% of the patients actually attained CR in relapsed refractory situation as a third line therapy. Overall response rates were about 46%. This is the orange one is the overall response rates, but if somebody was in CR, then the survival was significantly superior for both PFS and OS. And when this study was compared with the other second line options, one was the polatuzumab, bendamustine, rituximab. So the TAFA plus lenalidomide group was doing significantly better with a median survival of 20 months here versus 7 months here. Similarly, TAFA plus lenalidomide was doing better than rituximab plus lenalidomide, with a difference of 24 months versus 7 months in overall survival. The combination was largely well tolerated, with about 10% of the patients discontinuing treatment because of the adverse effect. Adverse effects were largely marrow-related, the anemia, thrombocytopenia, leukopenia, and then febrile neutropenia due to these. So practically for us, the TAFA plus LEN is an option for transplant in eligible patients who relapse after initial therapy of DLBCL. Their scheduling concentration, because it is weekly for first 3 months into the hospital. And the safety profile with initial hematological toxicity usually eases off over time. And the people who respond, we've seen the Kaplan-Meier, they have good chances of long-term disease control. Now, after second line, there are also sequential third line therapies available in DLBCL. And again, the 3 CAR T cell constructs as we discussed. And then again, the other anti-CD19 antibody, the Lonca. So this was a study on, the Lonca infusion. The first 2 cycles, the dose was 150, and then it was 75. And then every 12 weeks for 2 to 3 years, the patients were followed. So 145 patients with relapsed refractory DLBCL following 2 or more cycles of chemotherapy were enrolled. Overall response rate was about 48%. The CRs were about 35%. The median duration of response was 10.3 months. And with a longer follow-up, which was presented in this ASH, the median duration of response had moved from 10 months to 13.7 months. And incidentally, the patient with Lonca, patients who had prior CAR T cell therapy, still there was an overall response rate of 46%. So fairly decent activity. And these are the overall intent to treat survival curves. But of course, if you were in CR or some kind of partial remission, then the survival chances were significantly better. So the practical considerations of Lonca, which is again an anti-CD19 antibody, is the adverse effects are largely the edema, effusions, photosensitivity, and a non-specific GGT increase. And for someone who is having an adverse effect beyond a particular stage, then steroid pre-medications reduce that, and dexamethasone on day -1. It starts a day before this medication give 1 and 2. And again, there was another study on Lonca plus ibrutinib, which was showing encouraging anti-tumor activity, with overall response rates of 57% and 77% in the GCB DLBCL with a manageable safety profile. So the next wave of innovation are, the bispecific antibodies in this. and one of them is mosunetuzumab. What bispecific antibodies for the students who might be hearing this session is basically this antibody would bind to CD20, which is present on the lymphoma cell. At the same time, it binds to the normal healthy CD cells, the T lymphocytes. And this basically brings that, cellular cytotoxicity directly close to the lymphoma cell. So there was an abstract on the use of mosunetuzumab plus polatuzumab in 63 patients. Again, the overall response rates were about 65% with CR rates of about 48% in this patient. The cytokine release syndrome was seen in 11 out of these 63 patients. 18% had grade 1 and in 10 patients, and grade 2 was seen in only 1 patient. Most of the other side effects were about neutropenia and fatigue. So again, fairly well tolerated. Similarly, there is another glofitamab, which is a T cell, basically a BiTE, a T cell engaging bispecific antibody, in which the 2:1 ratio is maintained in this. And again, glofitamab plus polatuzumab vedotin was safe in relapsed refractory diffuse large B-cell lymphoma. And when this was used, so there was a dose escalation cohort and then an expansion cohort. Then overall response rates was 73% and the CR rates were 51%. The CRSF neurological events were limited to grade 1 and 2, and no new safety signal was noted compared to the previous study on this molecule. So where will bispecific antibodies fit in DLBCL? So, we talk about CAR T cell, but then CAR T cell, you need a lymphodepletion and your patient specific, there's a manufacturing there. Bispecific antibodies are like off the shelf. You order it, you can just get it like any other, medicine and use it. And it is anticipated that, some of these bispecific antibodies will get approval in DLBCL. The question remains is how do we sequence? Do we use the monoclonal first, the bispecific CAR T, and in which form? So we'll move to the CAR T cell therapy in DLBCL. And as we know, it is approved as a third line and subsequent therapy. And majorly, there are 3 CAR T cell constructs. One is an Exica, second the Lizo, and the third is a Tizagen. And there are 3 main trials on this. The Zuma one is on Exica, Juliet is for Tizagen, and Transcend is for Lizo. And there were no new study published, but basically the follow-up data of these were published. Now, in real life situation, we have to see that the patient who is found to be eligible for CAR T should have received 2 or more lines of therapy, should not have an active infection, or for that matter, any inflammatory disorders also. We do need a lymphodepletion prior to CAR T cell infusion. We need to watch for neurotoxicity. Steroids are generally very effective in that. And we need to monitor for relapse and recurrence. So the Zuma trial, the further follow-up data was published and in this conference. And they found that when the follow-up was extended to 5 years, the 5-year overall survival was 42%. And if somebody was in CR, it was about 64%. The median overall survival was not reached in patient who had attained complete response after XC-cell CAR T cell therapy. In Juliet, again, a longer follow-up was available. And if you were in some kind of CR or PR, the long-term survivals were better. And the 24 and 36 months PFS were 33 and 31% respectively. Overall response in this group was 53%. Then the third CAR T cell trial was the Transcend NHL1 trial, which basically enrolled Lizo cell. And again, if you are in CR or some kind of PR, the long-term PFS was significantly superior. And this time also they showed that it has a favorable safety profile also. So what is the real world evidence with these CAR T constructs? So this is the real world data outside of the trial, and they have found that the standard of care therapy versus Exica trial, the results were more or less similar in terms of whether it was a PFS or whether it was OS. The median follow-up duration in this real life study was about 13.8 months. And the real world experience with, again, CD19 CAR T also showed that patients who had better ECOG status or normal LDH were doing better than people who had high LDH. Basically, high LDH was reflective of a rapidly progressive disease or a poor disease biology. But in real life, there are a number of barriers to delivery of this cellular therapy. And the factors limiting these are basically one, disease progression. Many times by the time you plan, do, and actually want to use CAR T cell, the disease progresses, and many times soon after also. Infections are a major concern. Manufacturing failure. Of course, most of us would not have the in-house CAR T facility. And then, of course, there are socioeconomic barriers for the use of the CAR T cell therapy. I think majority of us would have read about this, the cytokine release syndrome and the neurological events. And these are the different timelines of when cytokine release happens and when the neurological event happens. Usually by day 17, the neurological events settle. Now the future is for the CAR T, which was as a third line, to bring it to second line and compare it with the standard of care. And that standard of care in otherwise fit person is a salvage followed by an autologous stem cell transplant. So there were three head-to-head comparisons of the CAR T constructs along with the ASCT. The Belinda trial, phase 3 relapse refractory DLBCL, Zuma 7, again phase 3 relapse refractory DLBCL, and Transform trial, phase 3 relapse refractory DLBCL. So an update of this Belinda trial was presented in this ASH of Tiza-cel versus an autologous stem cell transplant as a second-line therapy in relapse refractory. And this actually did not improve event-free survival. It was 46% versus 43% in both the arms. CR rates were similar. And at the time of this data analysis, the OS was data was immature. But for XC-cell versus SOC, patients on patients who received this CAR T cell had a significantly superior progression-free survival compared to the standard of care, which was salvage chemo followed by an autologous transplant. So the 2 years EFS rates were about 41% versus 16%. And similarly, the ORR and CRR rates was also significantly lesser in transplant arm compared to the CAR T cell therapy. So ORR was 83 with 50% CR in CAR T cell therapy, while it was 65 and 32% in
Dr. Rahul, sorry to interrupt. Last minute, can you finish?
Sure. And similarly for the Liso-cel also, they documented that Liso-cel CAR T cell construct fared better than the standard of care, which was the transplant. So the take-home messages on CAR T for DLBCL is there are multiple CAR T constructs available as third-line therapy as of now. It produces impressive ORR and CR rates in relapsed refractory lymphomas. Remissions are durable. Comparable results are now seen in the real-world population. Toxicities are manageable once we are aware of it and we gain more experience with that, along with improving supportive care. And it's going to be a expansion of CAR T footprint in the management of relapsed refractory DLBCL. Thank you.
Dr. Rahul, there is one question in the chat box by Dr. Vishnu for your suggestions for young double-hit lymphoma patients relapsed within a year of RDA POCH. So,
what's the question? How to manage that?
Yeah.
If you go by the disease biology, for somebody who is relapsing within a year of therapy, and whether it's for DA POC or for that matter, even if it was RU, several trials have been done using the bortezomib, lenalidomide, ibrutinib. Nothing has worked. In fact, these are the patients where we need to use monoclonal antibodies or go for CAR T cell. CAR T cell will not be allowed here, but these are the patients. And this is also the group which is relapsing within 1 year, where even with salvage chemo and autologous transplant also, the long-term survivals are not more than 13 to 15% in the published literature. So these are the patients where one should go for more definitive therapy. And if somebody is young, allo transplant would be on card.
Thank you, Dr. Rahul. Excellent presentation. So we'll move on to the next session. Dr. Hari Menon, he's a professor in hematology and head of Department of Medical Oncology at St. John's National Academy Health Sciences at St. John's Medical College Hospital, Bangalore. And sir will speak on DLBCL and follicular lymphoma key updates from ASH 2021. Over to you, sir, Dr. Hari.
Can I start sharing my screen, please? Yes. Yeah. Thank you. Is my screen? Yeah. Sorry. Yes. So the topic of discussion today, which Rahul has covered quite a bit or touched on quite a few of that in my discussion. So it is basically on the key updates from ASH 2001 in relation to diffuse large B-cell lymphoma and follicular lymphoma. So let's take the first topic of diffuse large B-cell lymphoma.
Sir, can you make it full screen?
Yes,
sorry.
yes.
So.
Yes, thank you. Yeah, sorry. So when we talk about diffuse large B-cell lymphoma, as Rahul had mentioned, that we expect about 60% of them to be cured. It's a fast-growing tumor. And we know that there's a substantial unmet medical need over here because we do encounter about 40% of the patients relapsing to standard therapy. And the first-line standard of care, which is rituximab plus the CHOP regimen. And despite many efforts, R-CHOP still remains one of the standard of care. And if you look at the data, the one improvement that has happened has always been the introduction of rituximab to the chemotherapy regimen, and nothing else has actually translated into any great benefit in patients, in those 40% who do not respond to standard therapy. And we have tried looking at newer antibodies like obinutuzumab in terms of enhancing the anti-CD20 activity, the use of lenalidomide, the robust study, again, not much of a benefit, the use of bortezomib, the remodel B study, which did not show any benefit. So addition of any targeted therapy, including ibrutinib, may be some responses in the ABC subtype, but not so much in the rest of the population. And again, bevacizumab in addition treatment, most of these treatments did not yield any benefit. They either ended up as a failure of any response to addition of any of these novel agents, or landed up with toxicity. So that those toxicity things were including addition of chemotherapy, like gemcitabine, and also when we use the infusional protocol like dose-adjusted EPOC with again, it did not show any survival benefit in these patients. So, the first thing that actually showed some sort of an outcome was, again, the use of the newer antibody, which is polatuzumab, which showed activity in patients who relapsed refractory diffuse large B-cell lymphoma who had failed first-line therapy. Basically, polatuzumab, as we know, is an anti-CD79B targeted drug conjugate with a potent antimitotic agent called MMAE, which targets the B lymphocytes. And this is structure. It has an inactive Fc portion, a binding site to the CD79B, and a cleavable linker, which actually links to a potent cytotoxic microtubule disruptor, which gets released as goes as a payload and gets released into the targeted cell. So we know that the combination of polatuzumab in combination with bendamustine rituximab yielded some benefits in patients who had a relapsed refractory disease and who had failed more than 2 lines of therapy. And so this POLARIX study was a study that looked at bringing polatuzumab into frontline therapy for patients, adding it on the backbone of rituximab and CHOP versus the standard R-CHOP regimen. And this was a phase 3 multicentric randomized double-blind placebo-controlled trial, which looked at R-CHP versus R-CHOP in these patients. And so this is a drug design, the study design, where you have polatuzumab vedotin plus R-CHP versus R-CHOP standard regimen, in newly diagnosed patients with IPS score of 2 versus 3 to 5. And the stratification factors were bulky disease and geographic region. So when you looked at the safety summary of these patients, the overall safety profile of polatuzumab with rituximab CHP was similar to the R-CHOP regimen with no additional toxicity that was associated. The drug deliverability also favored the use of polatuzumab with R-CHP versus R-CHOP regimen with lower incidence of adverse events leading to any dose reduction in the study arm. And many patients received all the planned doses of polatuzumab. Again, concerns about febrile neutropenia were marginally higher in the polatuzumab arm, 14 versus 8%, but this did not translate into greater overall rates of infections just because the polatuzumab was incorporated into the standard regimen. So this was the investigator assessed progression-free survival, which clearly demonstrated that there was an improvement in progression-free survival in these patients as against the use of standard R-CHOP regimen. And the 12-month progression-free survival was significantly better at 83%, favoring the polatuzumab arm. And at 24 months, it was healthy, closer to a little more than 6%. As against the standard R-CHOP regimen, again, the study did not. It met its primary endpoint of better event-free survival, but it did not translate into overall survival benefit in these patients. This was published in the New England Journal recently, the POLARIX study, and to me, it met its primary endpoint of event-free survival and with a significant and meaningful improvement in progression-free survival in these patients. And it resulted in a 27% reduction in the risk of progression, relapse, or death as against the use of R-CHOP regimen over here. So the endpoint was met. And to me, it looks very much akin to the Echelon study where brentuximab, when added to the standard ABVBD regimen, resulted in some sort of a 4 to 5% better outcome. But on long-term results, now we have the recent update where there is a benefit, and we hope that might also be translated in the POLARIX study. So it's the first trial in 20 years showing superiority over R-CHOP, and the POLARIX demonstrated a positive benefit risk profile with 27% reduction in the risk of progression-free survival. And this was a global collaboration with the LISA group and published in the New England Journal recently. So probably an important drug in the armamentarium in the future. So I just come back to when completing the data as for diffuse large B-cell lymphoma in primary treatment of diffuse large B-cell lymphoma, and also not the primary treatment, in relapsed refractory disease, the use of CAR T cells. And there were 3 phase 3 data presented at the ASH this year. And as Rahul had mentioned, the ZUMA-7 study, which is a phase 3 randomized study using axicabtagene versus standard of care in relapsed refractory disease. And they really looked at patients who they compared actively patients who would have gone into the standard regimen of chemotherapy with autologous stem cell transplant, who had relapsed within 12 months of treatment. And as mentioned, the event-free survival was benefiting the patients on the CAR T cell therapy arm. And the inference from the study is that those patients whom we anticipate as unfavorable and who relapse early in the treatment may be candidates for the use of CAR T cell therapy in these patients. And the second and the third study, again, was using lisocabtagene maraleucel, which was a transform study, which again looked at a similar set of patients. And this seemed to have a better event-free survival in terms of outcome, not so much different from the ZUMA-7 study, but certainly again showing that it improved the event-free survival as against improvement in overall survival, which is not met over here. But the third study, which is tisagenlecleucel, did not show a difference in the two arms, the Belinda study, it did not show a difference in the two arms as with a similar progression-free survival and overall survival of these patients. But when we are on the concept of CAR T cells, I would just allude to the same molecule when used as a subset. I mean, it was a subset analysis of a phase 2 LRS study where patients who were multiply treated follicular lymphomas, relapsed refractory follicular lymphomas, in these patients, decitabine had a profound activity in terms of long-term disease-free survival in these patients, close to about 60% in these patients. And therefore, it depends upon which indication that we use actively, and it is basically horses for courses, and probably decitabine has follicular lymphomas have a better benefit from the CAR T cell therapy in the same setting of relapsed refractory disease. So we come to follicular lymphoma again, and this was one of the abstracts which looked at obinutuzumab short duration infusion, which was preferred by healthcare workers on patient-reported symptoms among patients untreated advanced follicular lymphomas. And patients with follicular lymphomas who had initial treatment with reported low levels and high quality of life index in patients, in the Gallium study, the patients treated with obinutuzumab chemotherapy followed by obinutuzumab maintenance reported low levels of symptoms, and the short duration infusions of treatment for patients with untreated follicular lymphoma may yield substantial time saving for patients in these patients. And the Gazelle study was a prospective open label multicentric single arm phase 4 study which evaluated the safety of obinutuzumab with administration in short dose infusion from cycle 2 onwards. And this was the study pattern where regular infusion in cycle 1, G chemotherapy, obinutuzumab 1,000 milligrams on day 1, and if they did not have any infusion-related reaction, then they were put onto a faster dose of 90-minute infusion. If there was any grade 3 infusion reaction, they received regular infusion, and the result was that the standard dose infusion appeared to be safer with no grade 3 infusion-related reactions. But this analysis reported symptom levels as far as the provider preference. And if the patient did not have any symptoms in the primary treatment, then they could be switch to a faster dose, thereby reducing the duration of infusion in such patients. So then there was the phase, which again Rahul alluded to, which was the use of mosunetuzumab, this time in the treatment of follicular lymphomas. And mosunetuzumab monotherapy is an effective and well-tolerated treatment for patients with relapsed refractory follicular lymphomas who had received more than 2 prior lines of therapy. And this was the pivotal results from the phase 2 study. As mentioned, mosunetuzumab is an anti-CD20, anti-CD3 bispecific T-cell engager, and it is CD20 into CD3 bispecific antibody. And the results from the phase 1 dose escalation study showed promising efficacy and manageable safety for mosunetuzumab in relapsed refractory follicular lymphomas. And the current analysis was a pivotal phase 2 result of mosunetuzumab in an expansion cohort of patients with relapsed refractory follicular lymphomas. And these were patients greater than 18 years of age, mosunetuzumab day 1, 1 milligram, followed by day 8, 2 milligrams, and day 15, 60 milligrams, followed by maintenance continuation of mosunetuzumab day 1, 60 milligram, and then subsequent, and then discontinue if CR by cycle 8 was achieved. So, the results were exceedingly impressive in terms of the responses, and these were the baseline characteristics. In the interest of time, I'll just go ahead. And the very impressive results in terms of the response rate. The best overall response is CR rates in all the more than 3 lines of relapsed refractory patients in pre-specified subgroup by PET scan assessed by independent review board. And the overall response rates were 79%, as 79%. The patients with with 2 prior lines of therapy obviously had a better outcome as against 3 lines of therapy, and patients with disease refractory to any prior anti-CD20 still had a response of almost 76% in these patients. So overall, in terms of safety, there was a slightly higher, safety-related features, but nothing which was dose-limiting. And most, if you look at adverse events, it was close to 90% in these 90 out of the 100. 90% in these patients, and the grade 3, grade 4 toxicity was 63%. And when you looked at the adverse events in terms of CRS in these patients, the grade 1 was around 23, grade 2 about 15, but grade 3 and grade 4 were hardly anything to go by. And the median duration in terms of the CRS was about 3 days in these patients, perfectly manageable and well tolerated. So in conclusion, the treatment with mosunetuzumab resulted in a CR rate of 60%, an overall response rate of 80% by the independent review committee. And the fixed duration treatment approach demonstrated deep and durable responses in high-risk patient subgroups. And mosunetuzumab had a manageable safety profile, step-up dosing, effectively mitigating CRS significantly, enabling treatment without mandatory hospitalization in these patients. So probably next kid of the block, basically it would appear that follicular lymphoma, as would be expected, would have a better response to immune modulation, as we saw with the CAR T-cell therapy and with mosunetuzumab. But having said that, we have a new strategy on the horizon in another antibody that can be combined with rituximab, perhaps for better outcomes. And with that, I will conclude. Thank you.
Thank you, sir, for an excellent presentation. And I don't see any questions in the chat box. So I think I'll hand over to the organizers for the next session.
Thanks. Thanks, sir, respected chairperson and speakers. So it's a very nice brief overview of recent advances in the field of lymphoma. So now proceeding with our third session, it is our last session. That is recent advances in the field of myeloma. It is also a very interesting topic. For that, I would like to invite our chairperson, Dr. Sandeep D'Souza. He is a medical superintendent in State Cancer Institute and head in the Department of Medical Oncology at SMS Medical College and Hospital, Jaipur. And our second chairperson, Dr. Hemant Dadij, is a senior medical oncologist at Sudha Hospital and Medical Research Center in Kota. So over to sir.
Thank you, Ashish. I think Sandeep D'Souza is here.
I think, sir, he has not joined yet.
Okay. So for this session, I will invite Colonel Dr. Rajan Kapoor. He's a hematologist and hemato-oncologist, Command Hospital, Kolkata. He will talk about multiple myeloma updates from ASH for novel agents in India. Over to Dr. Colonel Rajan Kapoor.
Good evening. Am I audible?
Yeah.
Yeah. Can I share my screen?
Yeah.
Is my screen visible?
Yes. Continue.
Yeah, okay. Good evening. Thanks a lot to the organizers for giving me this opportunity. And I've been listening to these abstracts, wonderful sessions. So in ASH 21, myeloma had 70 plus abstracts. So obviously we can't cover all of them. So I've chosen the abstracts which are clinically relevant to us for the drugs which are presently available to us. Now, these are the studies which I've chosen. This is a Griffin, Maya, first line use of Dara regimens, which we all are now very comfortable with, the master trial, and finally the Bellini trial. I would like to thank Janssen Oncology for helping me with a few of the slides. So before we start the studies itself, it's very interesting study which I came across is this Iceland screens, treats, or prevents multiple myeloma. iStop-MM, which is a population-based screening study for monoclonal gammopathy, that MGUS, and control trial of follow-up strategies. A beautiful strategy. Iceland, despite being a small country, they decided to screen the whole population of the middle-aged as well as elderly for MGUS. The outcome is there were 6 oral presentations from this iStop-MM. So I just like to say how they planned the study. They decided that they'll take the samples from the urban institutes, the remote institutes in Iceland, as well as active sampling. They tried to screen, and they were able to catch more than 90% of the eligible population, which is phenomenal seeing. And this is to pick up a disease like MGUS and see what is the natural history. So what they did, they all participants, they were screening protein electrophoresis and the free light chain. So they were either there was normal or they were advanced studies which detected. So they were out of the study, and then it was MGUS. Now the MGUS were randomized into 3 arms. Arm 1, there was no further workup. Arm 2, they followed the guidelines of MGUS. What we follow is 6-monthly follow-up. And Arm 3 was the one which was an intensive follow-up, which has been designed at 3-monthly free light chain assays, PET scans, and other things. So this, if you see this graph, so this was started in 2016, and the active recruitment started, and they were able to target more than 80,000 population in more than 80,000 participants. So this is the phenomenon of the studies. This is the strength of the study. Now, there are 6 papers. The one was which was the most important, was for the MGUS, population-based randomized clinical trial. So these are the first results which were presented in ASH 21. So if you see, as we had said, there were 3 arms, 1, 2, and 3, and they are equally distributed among these 3 arms. Now, the isotypes are also equally distributed. But if you see the outcomes, so lymphoplasmacytic disorder were increasingly detected in active surveillance. So this was very high number. The arm 1, where nothing was done, there were only 9 detections, while there was 133. So now this is in developed countries, so they were able to offer the treatment. And similarly, multiple myeloma and smoldering myeloma were also detected actively. Now, why I wanted to show this study, obviously it is not possible in big country like India, but in selected groups like from armed forces where I am, it's certainly feasible to study a disease like MGUS and myeloma. So coming to myeloma, now what are the facts in myeloma? Incidence of myeloma definitely is increasing. In India, as all would agree, there are younger patients, and the paper in Blood Advances where they say in the West, the Indian origin patients are younger. So there's something to do with Indianness. It's a heterogeneous disease. So as has been brought out, there are multiple malignant clones at presentation. Until now, it has been considered incurable. The most important thing is whenever we diagnose a patient, we tell them that there are multiple remission and relapses. But the most important fact which we have to remember, the first remission which a patient achieves is the longest, and the duration of subsequent remissions progressively decreases drastically. This is very important. So whatever we have to prolong the first remission. The best quality of life is in the first remission. So this is a very commonly showed slide. So how we treat myeloma: we transplant eligible, ineligible, we do induction, consolidation with the transplant, and go on for maintenance. While ineligible, there is induction followed by continuous therapy. And as we see in the lower graph, the tumor burden goes down rapidly. Now I'll start with the transplant ineligible patient. Now, what are the issues in transplant ineligible? There are comorbidities, there is a frailty which we have to assess, polypharmacy, psychological issues, limited mobility, and this is the last line is the most important. This group of the patient, only 1 line of treatment, especially in India, there is no second line. So just 1 line is there. So this is the paper which was presented by Usmani et al. This was a poster presentation on the phase 3 Maya study. Now, as all would know, the Maya study was the one which showed unequivocally that adding daratumumab to lenalidomide and dexamethasone in transplant eligible patients improves the outcome. So this led to the approval of upfront use of daratumumab. So this study was on the patients with a renal insufficiency and the dose of len. Now, Maya study design, as we are eligible, as we all know, that more than 65 years who are ineligible for transplant were given Dara, Lendexa, and they were compared with Lendexa. Now, then this long-term follow-up, and primary endpoint was progression-free survival, and secondary endpoint was overall response rate and the CR rate, and MRD was also targeted in overall survival. Now, the overall responses which was presented in the ASH 20, as we expected that it's adding Dara to Lendex improved the overall response rate, the stringent CR and CR, all parameters were improved. Now, again, this was an abstract which wanted to see which is the safest and the most efficient treatment whenever the elderly are considered. So if you see on this plot, the topmost right are the most efficient and safest, and the least efficient and the least safe. So if you see, whenever we combine Dara to any of the combination, the efficiency and the safety factor is improved. While you compare with others, they are either in the middle or going down the line. So it does show, this is a meta-analysis of various randomized controlled trials that shows that adding Dara increases efficiency and remains safe. Now, coming back to the poster presentation, this was the many important thing is whenever we have renal impairment, we all want to know what is the ideal optimal dose of Len. Earlier, we used to not give Len, but now we know that we should not deny the benefit of Len to even patients with renal impairment. Now, there were 737 patients who were randomized, 368 in DRD arm and 369 in RD arm. Among the patients with renal impairment, 37 patients in the Dara arm and 43% patients in RD arm received a Len dose of 25 milligrams. This is important. This is the optimal dose. However, the patients who have a renal impairment as defined by less than 30 to 50 ml per minute were receiving less than 25 milligram. They were receiving 10 milligram of the lenalidomide dose. Now, with a median follow-up of close to 6 years, there was a PFS benefit as has already been shown. Now, the important thing is that DRD showed PFS and OS benefits versus Lendexa in patients with renal impairment who received a Len dose of 25, who were given 25 milligram dose DRD scored over lenalidomide, Dexa. When PFS and OS were also prolonged even if the Len dose was less than 25 milligrams. So this is a very important fact. So in some patients whom we are not able to give full 25 milligram of Len, combining Dara will improve the response. So this is the author's conclusion that 5 years follow-up, PFS and OS benefit of adding on Dara were observed in patients with renal impairment regardless of the Len starting dose. So what is important for us, if there is a newly diagnosed myeloma who's transplant eligible and due to renal impairment, if we are not able to give Len of 25 milligram, it makes a case for adding Dara upfront. Now, this was a very interesting second paper, which I'm going to discuss with Fonseca et al. Is the first line use of Dara, Len and Dexa confers survival benefit compared with second line use of Dara based regimens in transplant ineligible patients with multiple myeloma. Analysis of different clinical scenarios. Now, these are the clinical questions which we all ask. In patients with newly diagnosed myeloma not eligible for transplant, should we use our best treatment first or save them for later? Better to use VRD or Dara based regimen. So what they did is they divided, this was a computer simulation which was used. So whether we gave first line therapy is DRD, then there has been some attrition rate, and if the second line treatment is POM or Carfil based regimen, or what we normally follow, give a VRD and then shift over to Dara based regimen, or give RD and then shift over to Dara based regimen. So first line, whether we have Dara or without Dara combination. So they took the data from Maya and the Flatiron study for VRD and DRD, and they decided that attrition rate, the upper limit was 58% or 27%. Now, this is the graph which you see this. Now, First, in the blue line is the general population survival rate at 84, 62, and 37, as we see in the y-axis the time. Now, the top graph is upfront first line use of DARA and second line use of Carfil or POM based. So you see it's the closest to the general population. If you use only VRD or RD, and then use DARA, in all these groups, please remember that DARA has been used, whether upfront or in the second line. But clearly, if you use it upfront, it gives an survival advantage. If you take a 58 attrition rate or a 27 attrition rate. So again, median OS benefit in this clinical simulation. So if you do DRD first line and POM-CAR in second line, it's 7.6 years, 5 and 4. So again, and even if you take the attrition of 60% or 27%. So this definitely makes a case for using DARA upfront. I mean, if we decide the DARA will be used first or second line, better to use in first line. So these are the conclusions which though this is a simulation and this got many limitations, but it does make sense that if we decide to use in transplant ineligible group, better to use DARA upfront rather than waiting for the later use. Now coming to this transplant eligible younger group patients. Now the questions are, we are spoiled for choices. Whoever is treating myeloma now is spoiled for choices. So what do we do? A young patient, cure versus control. Can myeloma join the elite club of curable hemat malignancy? Can there be a surrogate marker for cure so that we can stop the treatment? Depth of response prior to stem cell transplantation? And the most important, is there any interference with stem cell collection and recovery post-transplant? Can we cure myeloma? So there's a lot of debate. So with the availability of newer drugs, people are thinking that maybe we can cure. But however, if you see the current scenario, these are the Kaplan-Meier on the left side. These are the myeloma curve. This is the general population. This myeloma. Clearly, after 4 years, there's a dip. There's a lot of gap between the general population survival and the myeloma survival. This is overall survival from diagnosis and after 3 years. However, if you compare with DLBCL and Hodgkin's lymphoma, if you see this after 3 years, it's absolutely bang on as general. So we can say that after 3 years, this is almost curable malignancy, DLBCL and Hodgkin's. Myeloma, we have to do a lot of work and we have to cover up more ground. Can there be a surrogate marker? Yes. So if you see that in MRD, there is a lot of talk about MRD in myeloma. So even if there is a CR and there is an MRD negative, progression-free survival is very good. But if CR with MRD positive, again, there is a recent paper in Blood which says that CR MRD positive does very badly, but MRD negative is very good. So this is the paper which is, we all know, the Griffin study, which has used DARA plus lenvatinib in patients with transplant eligible. So this year, ASH, it was after 2 months of maintenance, they published the data. In short, this is the Griffin study where they do RCT between DRVD and RVD induction followed by transplant. Then there was a consolidation and then there maintenance. The maintenance was DR from monthly or 2 monthly. They shifted over to 2 monthly with len or len maintenance alone. Now this was the endpoints. Primary endpoint was stringent CR, and the secondary endpoints were rates of MRD negativity by NGS of 10 to the power minus 5. Now the treatment arms between both the arms were equally matched, as well as the high risk and the standard risk. Now, if you see at clinical cutoff, all patients either completed 2 years of maintenance therapy or discontinued study treatment. The median follow-up was 38.6 months. Now, in both the arms, DARA or without DARA, discontinued DR or R maintenance. Almost 20% of them, they discontinued. If you see this figure, this was equally equal. But more people in RVD arm discontinued due to progressive disease. Now, this is very interesting. Now, responses in Griffin deepened over time. So if you see the DARA containing arm, at the end of induction, it was 19%, went on to 27, 52, 80, and after 2 years of maintenance, it was more than 82%. So this is a phenomenal result. So compared to RVD, there also the responses improved after autologous and maintenance more than 50%, like 61% had more than CR. So response rate of stringent and CR were greater for DRVD versus RVD at all time points, with the deepest response occurring after 2 years of maintenance. This goes on to prove that longer you treat with an agent, deeper the response you get in myeloma. Again, they try to assess the MRD negativity, which we said is a surrogate marker for cure after 2 years of maintenance therapy. In the DIRA arm, MRD negative was 64%, and almost 80% were more than when they did an MRD and negative in more than 81%. So this also favored DARA containing treatment regime where the MRD negativity was much more. So this is again with MRD, again the CR, as the maintenance increased, the MRD rate went up to close to 64%, more than 60% had MRD negativity compared to 30% in RVD. And even after stopping the daratumumab, that what was the sustained MRD negativity, which was again more in DARA containing arm. So, and when they did a subgroup analysis, almost all categories of patients improved with MRD negativity. However, ISS stage 3 and a high risk. So this is the problem with all the studies. This risk group does not derive that kind of benefit with any of the treatment. That's the group which we have to focus on. Otherwise, all the other groups had a benefit of adding DARA to RVD. Now, what is the progression-free survival in this population? Median PFS, though, was not reached in either group. Now, there's a positive trend towards improved PFS for DARA-containing arm. And the important thing is the separation of the curve that occurs after 2 years. So after 1 year of maintenance, like, so if we continue DARA, then they derive the benefit. So one of the questions which was asked to the presenter was, do you feel that it was bad to stop the maintenance at 2 years? He said, yes, the people who have been continuing maintenance even after 2 years derive the maximum benefit. So we don't know what is the end point of maintenance. So median OS, overall survival, obviously it's the data is still not mature, so we need more time. So the OS is not different in the two arms, but progression-free survival, as we've seen, it is different in the two arms. So the most common adverse events, higher rates of neutropenia and cytopenias were there, and upper respiratory tract infection, but it did not lead to increased rate of discontinuation. Now the other thing, again, URTIs were there, but similar grade 3 and 4. Other concern is a second malignancy, which we know with the lead. So in DARA containing arm, they were more malignancy, but I guess we have to follow up for a longer time to see whether it's actually causing more cancers on follow-up. So the conclusions were, they support DARA plus RVD is induction, consolidation, and DR maintenance. Now, if we compare the Cassiopeia study where they did a VTD versus DARA plus VTD, there the second crossover after the consolidation was that even the VTD arm got DARA maintenance. So there is a case, if even if we are not giving DARA upfront, after autologous and as maintenance, if we can add DARA, probably it would deepen the response. As we had seen this Griffin that says that as the years progress of DARA, maybe maintenance, the depth of response in MRD increases. So addition of DARA to 2 years of R maintenance was well tolerated. So there is a phase 3 Perseus study where they are again DVRD followed by DR maintenance compared with VRD followed by R alone. Similar as Griffin. So we'll be probably having it next year. Now, the second trial in transplant eligible is the master trial, where now we are moving from 3-drug induction to 4-drug induction. And the 4th drug is DARA, KRD, DARA, carfilzomib, and DEXA, autologous. And the most important of master is the MRD response adapted consolidation and treatment cessation, which is our goal. And briefly, so they gave induction DARA, KRD 4 cycles, MRD by NGS, autologous. And then again, they did MRD. If their MRD was negative, they went into MRD sure. That means there is a treatment-free observation and they do a heightened MRD surveillance. If MRD was positive, again consolidation. Negative again comes here or goes on for consolidation and then go for lens maintenance. So the main thrust on masters was MRD adapted treatment. So the primary endpoint was to determine the MRD by NGS of 10 to the power minus 5. Secondary endpoints were toxicity, the response rate, and outcomes observation. The exploratory endpoints, this is more of an academic interest. Who are the patients who went on for 10 to the power minus 6? Baseline characteristic, the 123 patients were enrolled and 96% were MRD trackable and the median follow-up was 23.8 months. Now, these are the standard risks, high risk, and now they have come up with an ultra high risk. So two or more high risk cytogenetic abnormalities has been mentioned here, as you all know, they come into ultra high risk. So they were equally distributed among the groups. Now, the safety of having a 4-drug induction, the main thing was pneumonias, the cytopenias, and there were 3 deaths in this group. Now, this is very interesting. The best MRD response by the phase of therapy. So if we see that by NGS 10 to the power minus 5, MRD negative is the red and the positive is the gray one. It was 38, 65, and 80%. It went up to 80%. The important thing is that if you see, it's almost the same in all the risk categories. So that means if you add 4 drugs, MRD, irrespective of cytogenetic high risk, they achieve in almost close to 80%. And when they did it in this 10 to the power minus 6, the exploratory endpoint, again, the same thing, it is close to 66%. So this shows that if we add DARA to KRD, the MRD negativity comes irrespective of cytogenetic risk group. So again, it was equally distributed as we had seen either it. So if you add 4 drug, it obviates all the known risk factors. So if there's a best response by the phase of therapy, again, if we see more than 88% VGPR post-induction cycle 4. And MRD adapted consolidation, it is close to 100%. So that's phenomenal. If we have an MRD adapted consolidation, almost all of them will be in VGPR. But this is important. This is why very important to see all the curves when you read the abstract. Now, if you see by 1.5 years, almost 12 months, everything is hunky-dory. It's going on very fine. But suddenly after 16, 18 months, this ultra high risk group goes down. So there's a lot of gap, even PFS and OS. So the MRD monitoring till 18 months is very good. But after that, the patients who were MRD, even MRD negative, they don't do that well. So this is a risk group, ultra high risk with multiple cytogenetic abnormalities, which actually do not do well even after adding DARA. So MRD sure, 84 patients who achieved MRD sure with no cytogenetic abnormality, it was 62 and 63% actually had 2 or more. Now, the median follow-up is very small. That's what I was trying to point out. It's only 14 months. The real picture emerges after this. So risk of MRD resurgence 12 months after treatment cessation. Actually, MRD negative, we thought that if it's negative, it's going to stay. But if there's a poor risk, 30% of them actually progress very fast. So that is a problem with a high-risk cytogenetic. So the pattern of treatment failure, generally 7 progression during MRD sure, and most of them were in high risk cytogenetic analysis group. So the author's conclusion is NGS MRD therapy is feasible in almost all patients. Patients with a standard and high risk newly diagnosed myeloma have a similar depth of response and low risk of MRD resurgence of progression when treated with DARA, KRD, and transplant. Quadruplet therapy and achievement of MRD negative responses enables the exploration of treatment cessation. However, effective novel consolidative strategies should be explored to clear MRD and improve outcomes in patients with ultra high risk MM. So after 2 years, they do very badly. Now, finally, this was the paper which was presented by Dr. Shaji. This is the Bellini trial. The venetoclax, we still don't know where to place venetoclax in multiple myeloma. So the BCL2 inhibitor, as we all know, is combined with bortezomib and dexamethasone. They had shown in relapsed refractory multiple myeloma some activity. So Bellini was a randomized double-blind multi-center phase 3 study, venetoclax or placebo combined with bortezomib and dexa in relapsed refractory multiple myeloma. So in primary analysis, venetoclax combination showed significantly improved PFS and response rate, but there was important thing is increased mortality. So that is the catch when you add venetoclax in myeloma. So this is the short diagram. So venetoclax was 800 milligram plus bortezomib and dexa in a usual dose, placebo and bortezomib and dexa. Primary endpoint was PFS and key secondary endpoint was overall response rate, VGPR, quality of life. So baseline characteristics were matched. So most important thing which we were looking when we add venetoclax are these two, this translocation 1114 and BCL2 expression, which they did high or low. So if you see the PFS, this is the top line is when with VD and placebo. So this significantly in favor of venetoclax. Overall survival was not different in the two groups. However, the most of the benefit was derived with this group. This is translocation 1114. So if we add venetoclax in translocation 1114, it makes difference in progression-free survival. Now they had the opportunity to do the BCL2 high. Again, if their BCL2 expression was more, they derived more benefit.
A few minutes left.
Yeah, I'll just finish it off. So PFS and OS, if we see the translocation 1114 and BCL2 expression, largest PFS improvement is seen in this. So venetoclax prolonged PFS in these subgroups regardless of cytogenetic risk status. So there were a deeper response and not many side effects due to venetoclax. So the conclusion is that if we have translocation 1114 in case of myeloma or a high BCL2 expression, unfortunately, no one at present other than academic institutes are doing BCL2 expression in myeloma, but translocation 1114 is done routinely. So if there is 1114, addition of venetoclax improves the progression-free survival and overall survival. So this I have just picked up from the Twitter. It's a very fast response when you add venetoclax in translocation 1114 in 1 week, the creatinine comes down from 1.5 to 0.97 and normalization of serum free light chain. So venetoclax is an option in translocation 1114 myeloma. So key takeaways, we have a better understanding. Treatment options are improving by the days. Tailored therapy, MRD guided therapy is the future. And DARA is a gift, I think, which keeps on giving. We have a financial constraint, but it's a true team player. It has proven its value in every category of patient. And this is important. Don't save the best for last in myeloma. There might be nothing to save. With this, I finished.
Yeah, thank you, Dr. Rajan. It's excellent presentation. I think there is no question in chat box. And the last session is a panel discussion on multiple myeloma. So I think that will cover all questions. So for that,
yes, sir. So, sir, for that, I would like to invite our moderator, Dr. Pankaj Malhotra. Dr. Pankaj Malhotra, sir, he is a professor in charge in the Department of Clinical Hematology and Internal Medicine at PGIMER Chandigarh, Postgraduate Institute of Medical Education and Research. And for this discussion, we have 5 panelists. Dr. Hemant Malhotra, he is the Director of Oncology Services at Sri Ram Cancer Center in Mahatma Gandhi Hospital in Jaipur. Dr. Bahusahib Baghel is a professor and consultant medical oncologist at Tata Memorial Cancer Center in Bombay. Our third panelist, Dr. Narendra Agarwal, he is a senior consultant in the Department of Hemato-Oncology and BMT unit at Rajiv Gandhi Cancer Institute and Research Center in Delhi. And our fourth panelist, Dr. Rajat Bajaj, is a consultant hemato-oncologist and bone marrow transplant physician at SCG Manavata Oncology LLP in Nashik. And Yeah, and Dr. Ankur Mittal is a consultant hematologist and bone marrow transplant physician at Mohan Dai Koswal Hospital, Ludhiana. And last, Dr. Bhavin Shah is a director and consultant hematology at Vedant in Ahmedabad. So over to you, sir.
Okay, thank you. First of all, thank you, Dr. Upendra and Dr. Hemant for organizing such a beautiful conference. And the job which is given to me is to do a panel discussion on myeloma. And I think previous to that, my friend and colleague, Colonel Rajan Kapoor, has presented the ASH abstracts very well. I think very well, good summary of Master, Griffin, Bellini trials, which actually forms the basis of some of the points which we are going to discuss in this panel discussion. So we thought most of the time these days, people know how to treat myeloma. Upfront is VRD, VTD, VCD kind of a regimen for transplant eligible patients, followed by transplants. So we thought we will discuss about the relapse, what happens once there is a relapse, and there is some confusion, not exactly confusion, but the practices changes, and that's what we are going to discuss with the panelists, and many of them are my seniors, Dr. Hemant Malhotra, my colleagues, Dr. Bhau Saab, Dr. Narendra Agarwal, and Dr. Rajat Bajaj, Dr. Ankur Mittal, and Dr. Bhavin Shah. So let's start with the relapse post-transplant. So this is a patient who is a transplant eligible, a 50-year-old gentleman. He had IgG kappa disease, and at the time of diagnosis, he had anemia and bone lesions, and he was in ISS 3, but FISH was high risk, so he falls into a category of revised ISS 3 classification. He received standard induction VRD into 6 cycles, followed by auto transplant with melphalan 200 mg per meter square. And then he was put on maintenance with lenalidomide 10 milligram daily for 3 weeks a month, every 28 days. However, at 18 months, there was an increase in the kappa chains, though he did not have anemia or new bone lesions. The kappa lambda ratio was 3.5. That means there was increase in the kappa. So let's come to the discussion. So how would you proceed? And I would just like to know the practice of people. What do they do, in their practice? And I agree that there may be a variation in their practice. So we can start from the junior most, Dr. Ankur Mittal.
Good evening, sir. Sir, in this case, sir, how would you, sir? I would like to.
Would you like to do investigations, or would you like to wait and watch? Would you like to do investigations, or what is your thought at 18 months post-transplant?
Sir, 18 months the kappa chains are on the rising trend, so there is a biochemical relapse, and that is sure. Sir, I would like to consult the patient that the relapse is going to be there, and we have to restart the treatment. And for the workup, sir, we know the patient is a myeloma, means we know it, and we can get an protein electrophoresis done, and immunoglobulin levels can be repeated, and we can start with the treatment.
Okay, so we'll come to the treatment.
We'll come to the high-risk patient, sir.
Yeah.
Can we add bortezomib at the time of
we will discuss? We will just discuss about the treatment in our next slide. Maybe I can have opinion from Dr. Rajat Bajaj.
Good evening, sir. So first of all, I would like to see whether the patient has any lytic lesions. So I would do an imaging, a PET scan. If PET scan is not visible, then a low-dose MRI. If the patient has any lytic lesions, so I would say that this is a symptomatic relapse, or the patient has one of the CRAB symptoms. So I'll straight away go to salvage treatment, which is
so he did not choice. He did not have any new lytic areas, and there is no anemia, there is no hypercalcemia. So it is only a biochemical relapse.
So what I would do is I would just add dexamethasone to the lenalidomide. I would not increase the dose of lenalidomide because there has been enough evidence that if the patient is doing well.
Okay. So we will come to the treatment. So basically what you want to see is that whether there is a biochemical relapse or a clinical relapse, and then you will take a decision. Okay, we'll come to that. Maybe we can take opinion from Dr. Bhavin Shah.
This patient, he has a biochemical failure, but patient is asymptomatic.
Maybe we can ask Dr. Narendra Agarwal.
I'm audible?
Yes, you are audible. Please go ahead.
Yeah. So this patient is asymptomatic, but he has a biochemical failure, and the ratio, FLC ratio, is quite low. So in this patient, I would like to observe him. I will repeat the free light chain assay and immunofixation after 3 months. And then if it is in rising trend, we are aware that the patients who have even biochemical failure, if you don't treat it, they progress aggressively. So in that case, if it is a rising, then I will treat this patient.
Okay. So we have 2 opinions, wait and watch, and 2 opinions to treat. So let's see what Dr. Narendra Agarwal, what do you say?
Same. I think the patient is asymptomatic, so no further investigation. Just wait and watch, continue lenalidomide and repeat free light chain after, say, 2 months, 1 to 2 months, depending on patient symptom. And then take a call. If rising, if it's symptomatic, then to treat.
Sure. Dr. Bhausab, any difference of opinion?
No, sir, I agree. Most of the patient would be observed. I mean, it's very exceptional if his light chains are in hundreds, 400, 500. I would like to treat rather than having a renal compromise. But I agree, we don't treat symptomatic or symptomatic progression, sir.
Okay, so most are in favor of asymptomatic. So Dr. Hemant, sir, are you there?
Because of some personal family matter, he is not able to attend.
Okay.
He has come for welcome note, but for this panel session is not.
No issues.
Apologies,
So if Colonel Rajan Kapoor is there, even though he's not a panelist, but since he has taken so I am replacing Dr. Hemant with Dr. Colonel Rajan.
Yeah. So I probably would go with most of the panelists. Like if someone is asymptomatic, we'll still follow those criteria, or now that the new criteria, if the involved free light chain ratio is more than 100, then only we'll start treating. Otherwise, I think wait and watch and close monitoring. So I would also go with that.
All right. Okay. So most are in favor of observation since patient is asymptomatic and they would like to repeat, which is kind of okay. But some people feel that, this relapse has happened a little too early, at 1.5 years post-transplant. Generally, patients who are on maintenance therapy, they take at least 3 years before they show a relapse. So, I mean, both situations are okay, but yes, opinion would vary. Some people would like to treat because this patient was a high risk at diagnosis, and it's just a matter of time before you can see him relapsing. So if you want to wait for 1 to 2 months, it is okay. But some people would like to treat him, early, patient of high risk smoldering multiple myeloma who is going to relapse. Okay, so this we have discussed, wait and watch versus treatment. So let's say he has a rising light chains level, and we discuss about the treatment options, and we start from Dr. Ankur. He did discuss about adding DEXA, or Dr. Rajat discuss. I don't remember exactly. So let's go back to Dr. Ankur Mittal. What are your treatment options? And this patient, let's say, has a clinical relapse, or his light chains are going very high.
So this patient has already received VRD. So this time I would like to add either DARA-based regimen or Carfil-based regimen with the POM. Is either DARA plus.
Okay, I just gave this options. Okay, so choose the option from this, or you can make your option on your own option. Yeah.
Sir, either with Carfil, POM, DEXA, or DARA plus KPD.
So 4 drugs, either DARA, KPD, or KPD.
Yes, sir.
Okay. Dr. Rajat?
I agree. If we've got those kind of resources, then I would add Dara, Kafil, Pomdex. If not, then Kafil, Pomdex or Dara, Boltex.
Okay, so the question which basically we are trying to ask is whether 3 drugs or 4 drugs. So you would feel that if option is available, you would like to treat with 4 drugs, otherwise, and 4th drug is Dara. Otherwise, you would like to treat with 3 drugs.
Yes, yes.
Okay, okay. Dr. Bhavin?
Yeah, I would like to treat it with 3 drugs only. The 2 drugs we will change from the previous combination which we had received. So Dara plus carfilzomib or POM along with the Dexa is a better option.
Okay, Dr. Narendra, any difference of opinion?
Yeah, daratumumab is fine. I think Dexa is obviously there, but we have cyclophosphamide also. So I feel that Dara side Dex is a good salvage option for such patients who are relapsing early. And
okay,
we have these LAN and POM also. So anything can be given, but I will prefer Dara side Dex.
Okay, so you want to basically give alkylator along with Dara. Okay, Dr. Bhausab?
Yeah, so he's progressing on lenalidomide. So I mean, obviously I will not use that. And I think I would not be favoring POM also. So I will use Dara, Bote, Dexa. I think he has a fairly long time since he has seen bortezomib. And case to case basis, we may use quadruplet, etc., sir, but that's not a routine thing which I'm doing, sir.
Okay, good. Colonel Rajan?
Yeah, obviously, resources permit, Dara should definitely be there, and Dara Boti or Dara Carfildex, I still would go for a 3-drug regime, and I agree with Dr. Bhausab. Probably Len and POM I'm not going to use in this setting. Definitely bortezomib or carfilzomib along with the Dara. And that's it.
Okay, so that's great. So what I could actually gather is that, as we go from our junior colleagues to the senior colleagues, they become more of, little bit conservative. The junior colleagues are more aggressive in giving the therapy, but that's okay. So I think, as I said before, this is all opinions and in their practice. And I think we have data and points in favor of giving 3 drugs or 4 drugs combination. Definitely, everybody agrees that if patient can afford Dara, then use Dara in combination with 2 more agents. Dara and Dexa obviously is part and parcel of all the regimens. So Dara Dex is there, and then the other drug can be either pomalidomide, cyclophosphamide, or Boti. And some people prefer adding carfilzomib also. I would just say that it's good idea to do a repeat bone marrow examination, and if patient has acquired 17P, then probably a 4-drug combination would be better. Okay, so we go to the case 2, who is a transplant ineligible patient, 75 years old gentleman, IgG lambda, and he had hypercalcemia and bone lesions at presentation, but he was in ISS1. Although FISH did show 1Q amplification, he received Lendexa for 18 months. However, the M band remained stable as 0.2. Every 2 months the M band was done, it was coming as 0.2. It is not coming down, it is not becoming negative. So after 18 months of treatment, he was put on maintenance treatment with lenalidomide, 10 milligram. So Dexa was omitted and he was put on this. So 1 year after Len maintenance, that means almost 2.5 years after the initial diagnosis, there was a gradual increase in M band from 0.2 to 1.5. But again, there are no CRAB. So how would you proceed here? Quickly, Dr. Ankur?
So this is 75. So now the M band has increased from 0.2 to 1.5. So there is more than 1 rise in the M band. So that means there is this is a progressive disease. So now we have to look for, we have to plan some other treatment because he did well on Dexa and Len only. So I would not, I would like to proceed with the treatment in this case too. For this, so bone marrow was done initially, na sir?
Initially bone marrow was done, but yeah, right now, what do you want to do a bone marrow?
Sir, So yes, sir, we can do a repeat bone marrow. There is no doubt there is a biochemical progression is there, and the patient is a progressive disease. If the patient allows us, we can have a repeat bone marrow. Otherwise, there is an indication to start with the treatment. Even though the crab is not there, but M-band is still more than one.
Okay. Okay. So Dr. Rajat, any difference of opinion?
I think so, sir, because he's 75-year-old, I would be a little gentle on him. So with, I would not initiate the treatment as of now, but with the first sign of any of the crab symptoms, I would start bortezomib based treatment.
Okay.
So as of now, nothing, but if the patient has
Sure.
any of the symptoms, I would start treatment with
Sure.
bortezomib.
Dr. Bhavin, any difference of opinion?
No, I think I would like to go gentle with him. And if there is no symptoms, I will just observe him. And once he becomes symptomatic, I would add the treatment. I will change the treatment.
Okay. So almost the same opinion as in the first case. So if asymptomatic, you would just wait and watch. Dr. Narendra, any difference of opinion?
No, I think wait and watch.
Okay. Dr. Bhausa?
I agree, sir. Will
agree. Okay. And Colonel Rajan?
Same as a
Same. So, okay. So most people say wait and watch because this patient is, as opposed to the first case who was a high risk patient, here, the patient is not a standard high risk. Standard means that he had 1Q amplification, which does not fall into revised ISS, but some people do consider it as high risk. But I think one of the question here would be that the M band, which has increased to 1.5, in how much period of time this has increased? If it has increased in 3 months' time, probably his M band is growing very fast. Whereas if it is going to 1.5 in an year's time, that means it's very, very slow. So you can wait and watch, kind of a thing. Okay, this we have discussed. So we have another 10 minutes. So, okay. So let's say this patient requires treatment. So he received Lendexa followed by Len maintenance. What treatment would you offer to him? Doublet, triplet, or quadruplet? Dr. Ankur?
Sir, being 75 years, I would...
now he's 77 and a half, because 2.5 years.
Sir, 77, I would like to add some, like only low dose of cyclophosphamide, like 50 milligram daily, with that not much of IVs or not much of hospital visits. Or bortezomib can be another molecule which I can thought of, either bot dexa or kind of.
Okay, good. Dr. Rajat?
I would give bortezomib once in 2 weeks. If resources for DARA, then yes, definitely DARA. And dexamethasone also, I would cut down on the doses.
Okay, good. And Dr. Bhavin?
Yeah, so bortezomib plus dexamethasone, if afford, then daratumumab can be added. The POM-DEXA is another option that I think of. And occasional patient, I just give bortezomib dexamethasone.
Okay, Dr. Narendra?
I think bot dexa is fine, and we can add cyclophosphamide also, and any of the third agent. I mean, we can combine either pomalidomide or cyclophosphamide. I think it's fine. Even
but the point why I'm asking is just to know your practice. What exactly do you do in a patient who has received Lendexa? Which obviously I think we are using Lendexa as first line, and then Len maintenance. So what is generally your practice?
So we'll do, I think if a patient is on Len maintenance, low dose Len, and is relapsing, then we still can give normal full dose lenalidomide. So one of the option is adding lenalidomide, dexamethasone, full dose lenalidomide along with cyclophosphamide. And another option is just change over to bortezomib, Cy, and Dexa. So I will prefer first, I will add cyclophosphamide with full dose lenalidomide and dexamethasone.
Okay, Dr. Narendra Agarwal is quite impressed with cyclophosphamide and alkylator, which is quite good, actually, gentle, very gentle drug as compared to melphalan. So Dr. Bhausa?
Yes, sir. So I agree, sir. There will be some exceptional fit patient where even at this age, a triplet may be possible. And if that is the case, which is very unlikely in this case, because first line we chose doublet only.
Yeah.
So if he's a candidate for triplet, I will go for dara, bortezomib, dexa, because I want to give him the best drug at least now. And if
Okay.
he's not that candidate set, then the choice would be bortezomib, dexa. And I really don't use single agent DARA or DARA dexa much in Salvage.
Sure, sure. Colonel Rajan, relapsed patient. So, you know,
So,
you have reviewed the ASH
yeah,
abstract. So,
what I do in practice in this, actually we use melphalan also because this is transplant eligible. So we can do MPV, I mean bortezomib, prednisolone if he is not affording. So melphalan is also a good drug in transplant ineligible, which we often use in this setting. So that one option, and if everything finances is not an issue, yes, we can give an advantage of adding DARA to bortezomib dex also, because DARA is one of the drugs which does not require any drug modifications in elderly also. All the other drugs like dexa, bortezomib and other things are fought with things. So if DARA is affordable, that's there. But melphalan, I do use melphalan in this setting.
sure. I think so one of the drawback of panel discussion is, the patient is not in front of you. So obviously, as mentioned, that if the patient is frail and not very fit, so you would like to use just doublet, and as mentioned, bortezomib instead of weekly, you 2 weekly, and low dose of cyclophosphamide. So all those options are open. Whereas if the patient is fit enough, obviously you will use the triplet combination. So one of the question in the chat box, which I just saw, happens to see Dr. Ashish Verma said salvage chemotherapy VTD pace, possibly in the first patient, panelist opinion, VTD pace followed by allogenic BMT. So if we go to the first patient who was a high risk, I think all the panelists did not mention about this. So I'm not sure, people agree with this, although I agree that a young patient who is high risk, some people would feel for the same. And Dr. Ashish has also asked any opinion on CTD in case 2 if financial consent. I think CTD is also good, a good. Okay. So we have only 5 minutes. So we go to the last patient who is relapsed refractory, and let's see the panelist opinion, who's a 56 years, multiple myeloma, IgA kappa, all CRAF features, baseline renal failure, creatinine 3.2, FISH 1114. So Dr. Colonel Rajan did discuss about the Bellini trial. So he received VCD into 6 cycles, even though according to Colonel Rajan, this patient could have received VRD also. So he was given 6 cycle VCD followed by transplant with melphalan 160 milligram per meter square. Day 100 assessment, MRD was negative. He received maintenance bortezomib twice monthly. 1 year post-transplant, his hemoglobin went down, increase in kappa light chain. So there was a clinical relapse. So this time he received DARA with carfil and dexamethasone into 6 cycles. He achieved kind of a hematological kind of a remission, or a CR, I would say, normal light chain or stringent CR. So he was continued with the DARA carfil, dexa was omitted for another 6 cycles. However, after 12 cycles, there was an increase in the light chains. At that time, he was given cyclophosphamide, pomalidomide, and dexamethasone into 6 cycles. And light chains remained stable during 6 months of treatment. But then again, there was doubling of light chains after 6 months. Then he was given melphalan, prednisolone, and thalidomide. But there was continued increase in light chains and development of anemia. Creatinine was 3.5. Now the options. So let's start with the senior most this time, Dr. Bhausab.
Yeah, sir, I think you made it very obvious, sir. So probably he is a candidate who requires this novel agent, either a bite or, if possible, affordable a car. Or but coming to ground reality, considering the fitness and financial issues, probably the best available option, promising option would be venetoclax, in my opinion, sir.
Okay, good. I think 1114, so venetoclax. But if venetoclax is not available,
yes, sir. So he has seen alkyl later, sir, and my experience of bendamustine in myeloma, maybe because of age, renal failure, etc., is really not pleasant.
Okay.
So I tend not to use it, and we end up probably after this many line palliating the patient. So if possible, I will like to use venetoclax. I'm not sure which is creatinine and all these things. I know because as Dr. Rajan showed, his patient had tumor lysis after venetoclax. So it's going to be challenge again to use that drug, sir.
Sure, sure. Colonel Rajan?
Same from Dr. Singh, venetoclax looks like a good option. Bendamustine we have used, but as said, not great results in such setting. I have no experience of selinexor, but that has also been mentioned. I just read Dr. Vincent's recent, I think Mayo Clinic 22 myeloma. So they have written about selinexor also in such setting. So,
okay. All right. Dr. Narendra?
So yeah, venetoclax, I think it's easily available in India these days and can be given in this setting along with the bortezomib, dexamethasone, and thereafter allo transplant. But definitely it's a palliative setting, so I can't say much. Just hit and try.
Okay, okay. And Dr. Bhavin?
So if this patient is in US, he must have received CAR-T or BITE or BCMA therapy. But here we have an option of venetoclax, bendamustine, because he had renal failure. We cannot give bendamustine if the creatine clearance less than 40. Adriamycin or liposomal doxorubicin is a one option that we can think of. Selinexor alone, usually they don't work, so we have to combine it with somebody. So I think we have limited options, and whatever the base is possible for that patient, we should use that.
Sure, sure. Dr. Rajat?
I think so. I agree. If venetoclax is available, then venetoclax. If not, then I would probably try and use bortezomib with dexamethasone again, because it's been a while that he's been exposed to bortezomib.
Sure. I think fair enough. Dr. Ankur?
Sir, I agree with Dr. House. I've like venetoclax and liposomal doxorubicin. These two are the options which I do consider.
Okay, I think obviously this is a situation relapse refractory, and as mentioned, either palliation or if venetoclax is available, then use venetoclax. So here the dosages of venetoclax actually is up to 1200 milligram, which is totally what we have. We actually don't use AML. We don't go beyond 150 or 200, and most of the time 100, between 100 to 200. Whereas here the dose would be quite high. We have experience of using venetoclax in 11-14, but we could not go beyond 400 milligram, and there was no tumor lysis. So, and I think palliation is a good option. So we have 850, and we have finished our time. So I thank all my panelists for sharing their practice and participating in the panel discussion, and special thanks to Colonel Rajan for he has not seen this slide, so participating in the panel discussion. So special thanks to Colonel Rajan, and I hand over back to the organizers. Thank you very much.
Thank you, sir.
Thank you.
Thank you, sir.
So, with the concluding remark, I'm thankful to Dr. Pankaj Malhotra sir for that great moderation. Our panelists, Dr. Babu Saab, Dr. Narendra, Dr. Rajat, Dr. Ankud, Dr. Bhavin Shah, and apologies from Dr. Hemant Malhotra sir for personal reasons. Concluding our this talk, some concluding remark. We had first session on CLL. Our speaker was Dr. Amrita Ramaswamy. She talked about how we can target therapies in CLL, treatment sequencing, and adverse event management. So she had very well talked about, and she has taken into the journey of CLL treatment and how we can sequence targeted therapies in CLL. And now we have very limited indications for chemoimmunotherapy in patients of CLL. Only those patients who are fit, having IGHV mutated, having TP53 negative or 17p deletion negative, those patients are candidate for target chemoimmunotherapy. Or else for other patients, we can go for target therapies with ibrutinib, acalabrutinib, venetoclax, and immunotherapy. Regarding side effects, acalabrutinib has very less off-target side effects with less atrial fibrillation, major bleeding events, and hypertension. She also talked about Elevate TN trial, comparing acalabrutinib monotherapy with acalabrutinib Gazyva and Gazyva plus coramicin. There was a PFS benefit in those patients who are having high risk with TP53 and 17p deletion as compared to chloramicin and Gazyva, but there was no difference in the PFS and overall survival when acalabrutinib monotherapy was compared with acalabrutinib with Gazyva. She also talked about relapsed refractory chronic lymphocyte leukemia resonant trial, comparing ibrutinib with ofatumumab. So there was a PFS and OS overall survival benefit with ibrutinib as compared to the ofatumumab. So various target therapies, they have various better PFS advantage over chemotherapy. Then we had a great panel discussion by Dr. Pawan Kumar Singh on how we can customize our care in mantle cell lymphoma with BTK inhibitor, and how we can select, sequence, and have safety management with the patients of mantle cell lymphoma. And very elegantly discussed by our panelists, Dr. Gaurav, Dr. Amrita, Dr. Amita, Dr. Sujit, and Dr. Sudeep. We also had a session on lymphoma, second session. So it was the first speaker was Dr. Rahul Nathani. He talked about DLBCL, how we can integrate antibodies and cellular therapies into patient care. So various antibodies, CD19 antibody, loncastuzuximab, anti-CD79B antibody, polatuzumab, and CAR T cell therapy, combination of lenalidomide with tafasitamab, bispecific antibodies like mosunetuzumab in DLBCL, that is highly active in relapsed refractory DLBCL and can even treat those patients who have failed CAR T cell therapy. So very encouraging result with this bispecific antibody. He also discussed about cellular therapy with CAR T cell therapy, Zuma trial, Juliet trial, with various encouraging results. Limitation of using CAR T cell therapy was also discussed very elegantly by Dr. Rahul Nathani. We had second talk in this session on lymphoma by Dr. Hari Menon sir on DLBCL and follicular lymphoma updates from ASH 2021. So he talked about POLLUX trial, about polatuzumab, which is anti-CD79A antibody drug conjugate, comparing R-CHP plus polatuzumab versus R-CHOP in untreated DLBCL, upfront first-line therapy. So overall safety profile was similar with R-CHOP, with less adverse events with POLA group. PFS benefit was comparable with R-CHOP, better event-free survival, but there was no difference in the overall survival as compared to the R-CHOP. But POLA RCHP resulted in 27% decreased risk of progression and death. That was significant as compared to the R-CHOP. Then he also talked about CAR T cell therapy in relapsed refractory DLBCL and follicular lymphoma with encouraging results. In follicular lymphoma, ofatumumab, various trials, Gallium trial, Gazili trial, then mosunetuzumab in relapsed refractory follicular lymphoma. This is anti-CD20 and CD3 bispecific antibody with better overall response rate of 80% and CR rates of 60%. That was very encouraging with manageable side effect profile. This active new therapy is approved for those patients who have failed 3 lines of therapy in relapsed refractory settings of follicular lymphoma. Then we had session on multiple myeloma. This was the third and last session. Speaker Dr. Ranjan Kapoor very elegantly delivered his insight on updates from ASH 2021, how we can incorporate novel agents in multiple myeloma in Indian setting. So as you know that Indian people, the myeloma occurs in mostly in younger population. Regarding phase 3 Maya study comparing DRD versus RD, so improved overall survival, stringent CR rates and CR rates with DARA RD versus RD group. Then for transplant eligible multiple myeloma patients, whether we can cure such patients and with these newer agents. So any surrogate markers for that cure. So he discussed about CR with MRD negativity. In MRD negativity, those patients who are having CR with MRD negativity, they have more probability of attaining a cure in future. Regarding different trial comparing, we all know about this different trial comparing DRVD versus RVD in transplant eligible newly diagnosed multiple myeloma. So response rates, CR and stringent CR rates were better with DRD, DARA RVD versus RVD, and more MRD negativity rates up to the tune of 80% we've seen with the DARA group as compared to the RVD group. Then he also discussed about master trial. This was a trial directed with MRD based approach, DARA KRD in newly diagnosed multiple myeloma who are transplant eligible patients. So if irrespective of the high risk features, more than 80% of the patients, they attained MRD negativity. So he also discussed about Balinet trial in venetoclax in multiple myeloma by Shaji Kumar, when or placebo when combined with bortezomib and dexamethasone in relapsed refractory multiple myeloma. PFS benefit in VEN group more in those patients who have translocation 11-14 and those with BCL2 expression, and overall survival, but there was no difference in the overall survival benefit. Lastly, I want to thank our patron for this conference, Dr. Ajay Bafna sir, Dr. Himmat Malhotra sir, our scientific committee members, session coordinators, chairpersons, esteemed national speakers on sessions on CLL, lymphoma, and multiple myeloma. Thanks to our moderators for mantle cell lymphoma, Dr. Pawan Kumar Singh, on myeloma, Dr. Pankaj Malhotra sir, who has spared his time, and all our esteemed panelists for mantle cell lymphoma and multiple myeloma, all delegates who have joined today's meeting, and I'm thankful to our pharma colleagues, AstraZeneca, Janssen Oncology, Novartis, Pfizer, Bharat Serum and Mylan, and I'm thankful to all the delegates who have joined this meeting. I'm thankful to all of you for making this meeting a great success. Thank you all.
So thank you so very much on behalf of my colleagues, Surbi and Palak. It's a great learning, sir. Thank you so very much. And we say good night, stay safe till we then meet physically. Thank you so very much. Good night,
Thank
sir.
you. Thank you. Good night. Thank you.
Thank you all.